Hi, Dr. Srinivas. How are you? We're meeting after a long, long time.
Yes, sir. Good evening. Sandeep, sir. Good evening.
Good evening, Dr. Shruti. Good evening to you.
Hi,
Ajit, sir. Good evening. One more time.
I hope you can hear me.
I said Sandeep, sir. I think maybe there's an echo, sir.
Okay. Namaskar.
Hello. Can
Sir,
you
good
hear me?
evening. Yeah, yes, sir. Absolutely.
Okay, I'll just mute my mic.
Yeah, sure, sir. We'll be starting in 4 minutes. 3:56. We'll just start in 4 more minutes. Santosh, sir. Good evening. Sir, you're mute.
Good evening, Dr. Kataria.
Good morning. Good evening, madam.
How are you, sir?
Hi, madam. Fine.
Thank you for joining in.
Good evening, Dr. Kataria.
Good evening. Good evening, sir.
गुड इवनिंग कटारिया।
पहचान में नहीं आ रहे, मोटे हो गए हो बहुत।
डॉक्टर धीरेन मोटे नहीं हो सकते सर, बिल्कुल ये
है?
एवरग्रीन है।
सही बात है, इज एवरग्रीन।
डॉक्टर पवन
Sir, he's joining us. So अभी तक join नहीं किया. I can't see him on the group. He's joining us.
डॉक्टर श्रीनिवास आगे मैम।
जी वो आ गए सर ऑलरेडी।
गुड इवनिंग।
छोड़ दे।
गुड इवनिंग डॉक्टर श्रीनिवास।
गुड इवनिंग सर।
डॉक्टर गोपा।
Dr. Gopa is joining.
He is joining.
Okay. So Dr. Srinivas, it is a great achievement, sir. You opened the first, the facial pain clinic in South India.
Thank you so much, sir. Thank you.
Great, sir. Great. Very proud of you, boss.
Thank you, sir.
डॉक्टर धीरेन जब सोचेंगे सर, हम लोग तब दिल्ली एनसीआर में एक ओपन करेंगे सर।
अच्छा, मेरी आवाज
नहीं आ रही है आपकी
आवाज? Dr. Dhiren will plan in NCR region, then we'll open, sir, the clinic as Dr. Srinivas opened in South India, in Bangalore, the facial pain clinic. Dr. Dhiren, seriously, I am saying on a serious note, it is a very high requirement, और ये आप काम कर सकते हो. We all will be a part of it.
ठीक है
सर, अभी फोर्टिस ने और मैनी ये जितने एमएनसीज हैं, they had especially associated with the न्यूरो डिपार्टमेंट. एक जैसे हिमांशु गुप्ता जो है वो सिर्फ फेशियल पेन पे काम कर रहा है, जबकि आइडियली ये रीजन हमारा है. एंड ही इज द ऑर्थोपेडिक सर्जन सर. तो सर प्लीज इस पे आप सोचो. डेफिनेटली डॉक्टर श्रीनिवास को भी बुलाएंगे.
उनसे इनपुट लेके फिर शुरू करते हैं.
नहीं सर, जिस दिन आप सोच लोगे हो जाएगा.
ठीक है, बहुत जल्दी.
So now, with everyone's permission, I would like to start the session because it's already 4 p.m. Warm good evening, everyone. Welcome to day 2 of the International E-Conclave on Oral Cancer. Today, we are going to talk about a very interesting topic, which is synergistic care on inter versus multidisciplinary care for oral cancer. Last Sunday, we talked about the approaches of the oral cancer diagnosis, I would say, and how it can be redefined by using the latest technology which is available. And today, we're going to talk about how multidisciplinary care is going to really work out for giving better quality care to the patients. I would like to thank all the partnering organizations who have really worked hard to make this event very successful. Thanks to all those organizations who are there, and you can see them on on the screen, that have tirelessly worked for the entire month to make this really, really successful. Before we actually begin the session, just a quick reminder to everyone of all the participants of the forum to please keep the microphones on mute unless it is the faculty or the speaker. All the questions which are there can be put on the chat box. Our specialists are available to talk about them, to answer them those questions. And towards the end of the session, we will take some important questions from both the social media platform as well as those that are posted in the Zoom chat box. Raise your hands if you have any concern. Our moderators will get in touch with you. And in case there is anything which you need to know, just text directly to the host using the chat box. Just ensure that all the videos are on in the proper mode because this is being telecasted across multiple platforms, and any breach will lead to warnings as per the IT regulations of the country. With this now, I take great pleasure to invite the moderator for the first scientific session, Dr. Keshav Nathani, who is Senior Director and HD from Department of Dental and Maxillofacial Surgery at Max Multi-Speciality Hospital. Sir has worked as Director and Head of Dental and Maxillofacial Surgeon in NMC Hospital as well. He has been a member of IDA, Global Health Initiative, IMFF, Fellow of International Academy of Oral Implantology, and member of the Implant Study Group. He has won many awards and distinctions during the medical education training and practice, including the Lifetime Achievement Award by Yashvardhan Charitable Trust. So I invite sir to please take the scientific sessions ahead.
Thank you so much, Dr. Shruti, and the entire team of ICanCaRe. Thank you so much, Dr. Pavan, for giving us the platform for the second scientific session. And the theme of the conference is capacity building, and the day 2 theme is on interdisciplinary and multidisciplinary care of oral cancer patient, as Dr. Shruti said. Today in this chapter, detection, diagnosis, multidisciplinary management and post-management of patients with the oral cancer and improvement of their quality of life. The dental professionals are an important and integral part of the oncology care. So nowadays, before starting the session, nowadays most of the head and neck cancer units are currently led by the MDTs. That is the multidisciplinary team, because of the cooperation between the different specialized professionals involved in cancer care with overreaching goal of improving treatment efficacy and patient care. Joining the efforts from different professionals is thought to improve patient management. So early detection of pre-malignant lesion and also cancer lesion is a crucial issue for the head and neck cancer, head and neck region. Early diagnosis of oral cancer is vital for patient survival rate and also for future quality of life. In addition, a dentist has an important role in initial diagnosing of any pathology in oral region because of daily oral health practice. So today in the scientific session 1, I would like to invite Dr. Gopakumar, the chairperson. He's the professor and head of Department of Oral Medicine and Radiology at KD Dental College and Hospital, Mathura. Sir is a proud alumnus of the prestigious A.B. Sethi Memorial Institute of Dental Sciences, where he spent the first year of his career in academics as a teaching faculty. There, in his career as an academician, over the last 30 years in teaching, postgraduate, he has adorned the post of principal at Mahatma Gandhi Dental College, Jaipur, Rajasthan, and also my Institute of Dental Sciences, Pondicherry. A very warm welcome, Dr. Gopakumar. Shruti, I'm audible?
Yes, sir, you're absolutely audible.
Okay. And speaker for the first scientific session is Dr. Srinivas K. He is a consultant oral physician and dental surgeon, Manipal Hospital, Bangalore. Dr. Srinivas is having extensive experience of 19 plus years in the field of, the dentistry. He is a consultant at Sadhguru Facial and Dental Clinic, Bangalore. We are very proud of Dr. Srinivas K. He is the first to start exclusive hospital-based oral medicine and facial pain clinic in South India in 2003 at Manipal Hospital, Bangalore. Published many articles, around 27, 16 in the international and 11 national journals. Contributed 3 chapters on dermatological disease in textbook published in the Elsevier on oral medicines. Delivered many lectures, 49 guest lectures at various medical and dental conferences and clinical meetings. I would like to invite for the first, the scientific session of day 2, Dr. Srinivas K. He'll speak on osteoradionecrosis, prevention and care, dental perspective. Over to Dr. Srinivas K.
Thank you for the introduction, Nathani sir.
Welcome, boss. A very warm welcome, please.
Shruti ji, you have disabled participant screen sharing.
Oh, sir, I'm making
You
you a
have to make me a
co-host.
host.
Yeah, I'm making you a co-host.
Yeah.
In a second. Rishabh, can you please make sir co-host?
Good evening, Gopa sir.
Good afternoon to all of you.
Yeah. Sir, now you can go ahead. You're the co-host.
Very warm welcome, Dr. Gopa Kumar sir. Sir is the chairperson for the first scientific session.
Yeah.
Very warm welcome, sir.
Thank you.
Shruti ji, am I audible?
Yes, sir, you're audible and we can also see your screen. Please go ahead.
Can you see the pointer also?
Yes, sir, we can. We can.
Okay. So good evening, one and all. The topic of today's presentation is osteoradionecrosis, prevention and care, a dental perspective. Well, the incidence of osteoradionecrosis has widely ranged from 2 to 40%. And we all know that tooth extraction is an independent risk factor of osteoradionecrosis. There are also few studies that has documented that 5 years post-radiation also a patient carries a risk of developing osteoradionecrosis after extraction of teeth. Now, there are so many preventive dental care protocols for prevention of osteoradionecrosis. Unfortunately, they lack sufficient evidence. Now, we all have read and seen many comprehensive reviews which give us the protocols for preventing osteoradionecrosis, but a specific tooth level recommendation does not exist in any of these protocols. So today's my presentation will revolve around the specific tooth level recommendations to prevent the development of osteoradionecrosis. We all know what is osteoradionecrosis. Osteoradionecrosis is defined as a bone death secondary to radiotherapy and is characteristically seen as a non-healing area of an exposed bone for more than 3 months. Frequently seen in mandible and in molar region, characterized by pain, sensory disturbances, infection and fistulae, so on and so forth. Now, I'm not going to cover all these things. It will be covered by the second presenter. We will be concentrating only on caries, periodontal disease, poorly adapted prosthesis, tooth extraction and dental implants after radiation therapy. Now, dental assessment is a key for intervention. What is the most unfortunate thing is even today there are some centers where patients are not being sent for a dental assessment before radiotherapy. Referral of dentate and edentulous patients is very much necessary because even edentulous patients can contribute to osteoradionecrosis because of implant placements, implant failures and sharp prosthesis. A full mouth radiographic survey is definitely required before the patient goes to radiation therapy. I would like to mention a small study that was done in the year 2011. Amongst the medical radiation oncologists. This questionnaire comprised of questions related to dental consultation in patients who are planned for radiotherapy. I would say the results were not at all promising. Now, when a patient comes to us for pre-radiotherapy, what are we supposed to do? Scaling, extraction, restorations, topical fluoride. All of us do this, but what we neglect is caries risk assessment and patient compliance assessment. I think these two things are the major things that will give rise to a decision whether to do the extraction or to retain the tooth in the mouth. Let us see in the next few slides how to take a decision in these situations. Before we go ahead with the extraction part, I would like everybody's attention. Everybody please see that I have mentioned something called as critical radiation threshold. What exactly is this? The radiation dose received by the patient for a treatment of cancer. The critical radiation threshold is a dose above which a clinician begins making decisions to prophylactically remove teeth prior to radiotherapy. So this is a very important number for us. The second important thing for extractions is the ideal timing of pre-radiotherapy extraction. Literature says it is 7 to 14 days, but my take on this would be a minimum of 14 days gap should be there before the initiation of radiation therapy from the day of extraction. Now, when coming to decision making on endodontic treatment or retention or extraction, we will see it in the subsequent slides. If a patient is suffering from dental caries, periapical disease, what needs to be taken into consideration is what is the risk of infection, the oral health status of a patient, what is the prognosis of the patient who is suffering, what type of cancer he is suffering from, and whether the patient is having a good compliance, whether he is regularly visiting a dentist. All these things are taken into consideration. Apart from this, you should also take into consideration the anatomical area of the presence of the tooth. If the patient is having a poor oral health status, poor patient compliance, extraction should be the first decision. As far as possible, mandibular, premolars and molars, the decision should go towards extraction. If it is maxillary anteriors or maxillary premolars, you can still try and restore them and do an endodontic treatment. But by and large, all these four things have to be taken into consideration before taking a decision whether to extract or to restore the teeth. When we talk about the third molars, apart from all the other four factors that I discussed in the previous slide, time available for healing is the most important factor that needs to be considered. 14-day healing time is a must because by and large, we end up removing a little bit of bone or cutting the gum for removing the wisdom teeth. If the impacted teeth are completely embedded inside the bone, we don't need to do anything. We just need to observe. But if they are erupted, we need to extract them. An additional point that is important here is because of the radiation, there will also be a post-radiation fibrosis that will make access difficult for us to remove the wisdom teeth post-radiation therapy. With regards to periodontal disease, apart from the points discussed in the previous slides, patients' wants and desires is an important factor that needs to be taken into consideration here. Majority of the periodontal disease patients are asymptomatic and they don't want to get their teeth removed. It is our duty to counsel them and make them agree for a dental extraction procedure. To summarize, I would like to tell any patient receiving a palliative dose of radiation therapy or a dose below the CRT, teeth which are symptomatic that present a risk of infection has to be addressed prior to radiation. That means every patient has to be referred to a dentist before radiotherapy. Second thing, all teeth with moderate and severe periodontal involvement that will fall within the radiation volume are equal to or above the CRT, that is equal to or above 60 grays, should be considered for extraction and only extraction. Point number 3, teeth with previous endodontic therapy where an asymptomatic periapical lesion is present may be observed provided the tooth is adequately obturated and has been stable since treatment. My take on this would be extract the teeth because these guidelines are Western guidelines. Most of the patients who come to us who have an endodontically treated tooth with a periapical lesion, they don't have pre-op records. They don't regularly come to us for follow-up. We don't know whether they are going to end up coming for a treatment or further follow-up. So it is better not to take chance and extract this kind of teeth. And healthy unopposed teeth that may cause trauma to soft tissues within the radiation field, they have to be smoothened and they have to be reduced. And most important thing, 14-day gap as far as possible has to be maintained from the day of extraction to the initiation of radiation therapy. And as far as possible, we need to do a primary closure. If we see a patient post-radiation therapy, the most important things that we need to do is oral hygiene instructions. I personally feel first 3 months we need to see the patient once in 15 days. Once 3 months post radiation therapy, we'll have to call him once in 3 months, do regular cleanings, topical fluoride application as suggested, daily fluoride in the form of toothpaste, and most important thing, tobacco cessation is an important thing here, and management of xerostomia to prevent future dental caries and periodontal disease. Now, it is not in the scope of this presentation to discuss the treatment modalities of osteoidonecrosis. We use systemic and topical antibiotics, and surgical management strategies are also available. But I would like to highlight upon few things before ending my presentation. Everybody is very much familiar with the Marx paradigm. Because of this, the concept of hyperbaric oxygen came into picture. Yes, hyperbaric oxygen is a fantastic modality. It has got a moderate evidence based on Cochrane reviews. The intermittent application of hyperbaric oxygen therapy is the only intervention that has been shown to increase the number of blood vessels in irradiated tissue. The only disadvantage of hyperbaric oxygen therapy is availability. My dear friends, even today in a district headquarter place, we don't have the availability of hyperbaric oxygen therapy. That is the only disadvantage of this particular technique. In the early 90s, people started postulating another theory for the causation of osteoidonecrosis. They call it a radiation-induced fibroatropic theory. What they postulate is after radiation, there is an activation and dysregulation of the fibroblastic activity, because of which there is a formation of atrophic tissue within a previously irradiated area that will lead to osteoidonecrosis of the jaw. Based on this hypothesis, people started using a combination drug therapy, pentoxifillin, tocopherol, and clodronate. They call it as a pentaclo protocol. What exactly it does is, pentoxifillin gives a inhibitory effect on the fibroblast proliferation, tocopherol prevents free radical mediated injury, and clodronate, which is a first generation biphosphonate, inhibits bone resorption by reducing the osteoclastic activity. There are many trials available, many randomized double-blinded control trials available, which have shown promising results on using this particular therapy, but this has to be given for a period of 6 to 24 months. If there is an inevitable condition where we need to do an extraction post-radiation therapy, after 1 year of post-radiation, this is the protocol that we need to follow. Topical and systemic antibiotics to be given 10 days before to 7 days after extraction, along with hyperbaric oxygen therapy before and after the extraction. Now coming to dental implants. Implant success has been shown that it is inversely correlated to radiation dose. If it is clearly shown based on the studies that a dosage, if a patient is receiving more than 50 grays, implants are not preferred. Bone augmentation for implant procedures should not be done in an irradiated area of the bone. If the patient is having poor oral hygiene, poor compliance, and if he is a smoker, implant should not be choice in a post-radiotherapy patients. And it has been directly shown that implant survival rates are much, much lower in contrast to normal patients. So it is our take and what kind of cases we are selecting for implant processes post-radiation. I have just shown you what is present in the studies. Last but not the least, I would like to project one new study that has come out. This study is done on 73 patients in 2 centers with a follow-up of 2 to 5 years. What they have shown us here is they postulate that after radiation therapy, there is a change in the bone activity along the neurovascular bundles. They say that the osteoclastic activation and attenuation of osteoblastic function results in the loss of upper cortical border of the inferior alveolar canal. This study is done on panoramic radiographs. What they postulate based on their study is, if you get to take a panoramic radiograph for patients who have received radiation in the mandibular area, and if the upper cortical outline of the inferior alveolar canal is not visible, these patients are at an increased risk of osteoidonecrosis. With this study, I would like to end my presentation. Thank you for your patient listening. Shruti ji, I think I am on time.
Absolutely, sir.
Well, thank you, Dr. Srinivas, for an elaborate, explosive presentation in 10 minutes.
Thank you, sir.
included, all aspects of dental perspectives, as you had mentioned in the title, and you have given us a fair amount of idea when to extract and when not to extract, and then what should be the minimum time for at least 14 days, which is a very significant thing, I feel. And if you are deciding for radiotherapy in any of these patients, even though we have got simulators, we have got shields and devices, and today's IMRT and the types of stereotactic radiotherapy is a much more what do you call it, a safe option in radiotherapy. Still, as a double-edged sword, radiotherapy has got its side effects, and then osteoradionecrosis is sometimes an inevitable consequence. In such cases, definitely, it's our duty as an oral physician or as a dental surgeon or a person who's going to see these patients in case of a carcinoma or a head and neck cancer being irradiated later, and if they are referred to a dental surgeon, it is imperative from our part to do the risk assessment, as you have clearly mentioned, and then proceed with the infection not to further in such patients so that it can lead to osteoradionecrosis and its complications. The type of studies of pentoxifylline and other anti-hypertensive medicines, etc., which were used earlier in the so-called progressive fibroatrophy theory is also interesting, but then none of them have got any significant results. As you said, hyperbaric oxygen is an excellent, promising tool, and unfortunately, except for some of the military facilities that we have, some armed forces hospitals, except for those, we do not have hyperbaric oxygen in every other center. That remains a concern, actually, especially in our country, even in the state where I'm working in, the UP or even in Karnataka. When you look at that, we are not actually having access to many of these centers which have hyperbaric oxygen therapy. Thank you, Dr. Srinivas, for an excellent presentation.
Thank you, sir.
Over to you.
Keshav sir, you're on mute. Keshav sir, you're on mute.
Can you hear me?
Yeah, now we can hear you.
Thank you so much, Dr. Gopakumar, for chairperson remark. And now for the scientific session 2, a very warm welcome to chairperson, Dr. Dhiren Srivastav.
Thank you, Dr.
Dr. Dhiren Srivastav do not need any introduction, but still, he's a director and professor, ESIC Dental College, New Delhi. He's the past president, Association of Oral and Maxillofacial Surgeon of India. He's the editor, Journal of Maxillofacial and Oral Surgery from 2000 to 2002. Lifetime Achievement Awards. He got many awards, but World Dental Conference in Malaysia, more than 58 publications to his credit. Very warm welcome, Dr. Dhiren Srivastav, sir. For the scientific session 2, chairperson. And the speaker for the scientific session 2 is Dr. Ashish Kumar. He is HOD Radiation Oncology, Sterling Cancer Hospital. Dr. Ashish Kumar has done MD from BJ Medical College and GCRI and has experience of 16 years of clinical practice. He has commissioned total 5 state-of-art IGRT linear accelerator, including 3 two-beam machines, the versions 1.6 to 2.5 and IX units under his leadership in different parts of the country. He treated more than 5,000 cancer patients and has done more than 100 radiosurgeries successfully. He was a part of the team who used first image-guided radiotherapy in India and PET-CT radiation treatment planning in Gujarat. A very warm welcome, Dr. Ashish Kumar. And sir is going to present. He's the speaker for osteoradionecrosis prevention and care, oncology perspective. Over to Dr. Ashish Kumar.
Thank you. I'll be briefly starting our talk. I fully agree with Dr. Srinivas, what he said, and it is very unfortunate. I am audible, no? Hello?
Yes, sir, absolutely audible.
Yes,
We can
audible,
also hear you.
Yeah, so fine. It's very unfortunate after so many years of training, teaching, and people are not sending patients for dental evaluation. And I think there is no fun of doing so many lectures and still talking about this. The patients are not seen by the dentist, and it's very unfortunate. So, but anyhow, osteoradionecrosis is a spectrum of disease. It can involve any of the bone where radiation is given. for therapeutic reason, because if therapeutic radiation is not given, then you have to ready to seeing the cancer and its death. But naturally, when we save the life of the patient, there will be some amount of normal tissue death, and one of them is bone death. It can lead to the ribs, it can lead to the femoral heads, it can be hyoid, and most commonly mandible, which is a concern for all of us now today. Focusing on all the data, whatever it is, because many of the literature are biased, we need to believe in on our own experience, our own teachers, our own training. And I'm focusing on the last 10 years of the data. It is very clear that 75% of the patients require radiotherapy at some time of the treatment. Maybe primary treatment if this is unoperable, it may be adjuvant, or it's kind of palliation. And out of that, 40 to 50% are long-term survivors, and they are going to face many problems of surgery and radiation chemotherapy together. Xerostomia, trismus, so many issues are there, and out of that, ORN is also issue. It's a relatively rare now, but it's a really difficult for the patient. If I'm imagining that if I am suffering, then what will be the situation for me? And it's a costly treatment, but it's not fatal. It means it's not a fatal like cancer, but it is really troubling the patient for the rest of the life. And it's very difficult to prevent and hard to treat sometimes. As Dr. Srinivasa said, it's the death of the bone cells, and it can have a different variation. I wonder why there are so many variations. You mean to say people are not agreeing to each other? That's the reason. It can develop any timeline. I have seen one of the patients after 18 years of radiation treated by my own center where I was trained. And I have to re-irradiate the patient for another second primary of the tonsil, then landed up in a second primary in the hypopharyngeal cancer. No timeline for this. Death is a death. Now, there is a continuous trend. Now, incidence is reported as a 5%. And those, it's not only radiation, because around 30% underwent surgery with this part, along with radiation. Our data of 1,500 cancer patients are less than 2%. That includes the re-radiation. Mean to say it's not one radiation. We have given it twice radiation. And the cumulative dose is more than 100 days sometimes. Why it is less? But if you ask about my radiation oncology teachers, colleagues, group of radiation, it's around 5%. But it's contrary to that, the surgical teachers and surgical colleagues are reporting much higher incidence of ORN. Mean to say that it's a problem. Either we are not true from our heart, or there are some kind of thing which we are still missing. And what are they? We all know that pathophysiology, and it's still there. So many theories will come. But it is very clear from the biopsy specimens, those who has been irradiated will be having less vascular tissue. That everybody knows. And this is the recent studies which says there is no oxygen, there is no blood supply, there is no nutrition. What will happen? In the death. Everybody knows it. And we know that why mandible has more death. The reason is that naturally it is less vascular as compared to other bones, especially maxilla. And not only that, it is a bone designed for chewing. So it is at hardest. So naturally, there will be more cause of the death, and it is clinically seen 6 times more ORN than the maxilla. Older times, they kept on guessing that this many causes are there, but this is very clear that it is not only extractions. The main culprit is radiation itself that we need to accept. And it's the radiation dose. If you give higher dose, it will develop. This is the example that how is the radiation cloud happening in the buccal mucosa and alveolar health cases, where we are treating half of the mandible and half of the mandible is saved. Chances of developing ORN is there. But the problem is that to killing microscopic cells requires 60 gray, and tolerance of the mandible for this is 50 gray. So what we will do? We have to treat, either you have to accept the cancer or you have to accept the ORN. If you don't treat the cancer, the chances of recurrence is 30% to 70%. And if you treat with this, then the chances of ORN is 5%. So anyhow, we have to accept, no choice. The problem comes when we are treating the oral tongue. Mandible is not a target. In T1 to T3 lesion, there is no reason to treat mandible. But majority of the centers are keep on firing the mandible, and that is the reason where we can stop this kind of issues. When we treat the larynx, pharynx, oropharynx, early oropharynx, the half of the mandible, especially anterior mandible, is saved. Posterior mandible is relatively big, having a better blood supply, and we don't see the ORN in that cases. But the problem is that these are not operable patients because of the functional deficits. So we need to treat with a higher dose. And then, again, no choice. You have to treat these patients. And the major big problem starts when the oropharyngeal cancer is extending to the oral cavity and it's on inoperable. So what we do? 70K, fire both the mandible, both sides of the mandible, and what do you expect? Warrant, that's it. You have to accept. But are we really the reason? Suppose if you treat this kind of surgical patients, what we expect? We'll expect ORM patients because the metal plate has exposed. This example of the post-radiation, the metal plate is exposed. What we expect? ORM. Risk is more pronounced when we do the marginal bone dissection, and there is not many debates which will happen in the surgical piece. It is unclear that the chemotherapy adds ORM, but it's true. It's not affecting directly, but indirectly it affects because it increases the effect of radiation. Dental procedures. Earlier also it is claimed that the pre-radiation dental extraction also causes cancer because there is a trauma. But the problem is that if you don't treat now, then we have to treat this kind of disease, treat teeth in a higher risk. But we have to be very cautious when we treat this patient. We should not be over-treating the patient. And our policy is very clear. Do the extraction if it is not restorable. And that decision doesn't lie with us, it lies with the dentist. And we see to it, our department, none of the patient should be treated before seeing if they are not seeing the dentist. It doesn't matter, we have to lose the patient. Every month, we lose around 3 patients because they are not willing for dental extractions. Forget it. We don't want to change, we want to be cursed from that side of patient, so leave it. If they drop it, drop it. Another thing, what we see that we request all the oncosurgeons, especially in the Gujarat, that whenever you operate on the table, you do that extraction that time only with the same anesthesia. And if it is possible, involve the prosthodontics and the dentist that time only, everything is being taken care of. And fluoride treatment, I feel it's a real problem for us because many patients are not compliant for this, but we see to it that we do as much as possible. Another warning is that whenever we complete the radiation, we always ask the patient, whenever there is a need of extraction, please ask your dentist to communicate with us and get the dose profile so that he will be aware that what are the fair chances of developing ORM. And we always say that postpone as much as possible by conservative treatment by doing root canals and other things. But anyhow, all the dentist knows that how to do the post-extraction ORM. Now the data. It is a recent time in 2017 onwards the data came that what is the tolerance of mandible. If you treat mandible more than 50 gray, this is going to lead to ORM. So our job is to keep the dose as much as possible. And many times it is possible, many times it is definitely not possible. And it is very, very clear that a low dose of radiation is also more harmful than the maximum doses because we expose more of microvascular damage. This example, when we treat with the conventional treatment, whole of the mandible is treated. But if we do the IMRTs, we can spare some rim of mandible and it's vasculature. And definitely the chances of ORM will be less. But this is the example when we treat with the 3D, we can spare with IMRTs, where we can see the graph that the mandible is fully fired here, and we can save around 50% of reduction in the dose. And this is the help of the technology. But it's not always like that IMRT is beneficial because there are 2 different IMRT plans can happen, and radiation oncologist has to be adequately trained to see that which IMRT plan is good. You can see in the same patient, different plans are having different dose profiles. Here we can see much better sparing of the mandible, much better sparing of the mandible, much better sparing of the mandible. You can see that doses. And this is a very small, it is a very important, crucial step which nobody is aware except radiation oncologist guy. And if he is not aware of this thing, then he will lead to the osteonecrosis. It's very important for the surgeons to choose who are their radiation oncologists. Because radiation oncologist is always constrained not only the mandible, he has a lot many tissues to sell, including this many list of the organs. Because head and neck is full of the multiple organs. ORM is one part. Emergence of the image guidance has also helped us, but unfortunately the practice is not there for image guidance in head and cancer because still many people are using 5mm margins. If somebody uses the 3mm margins, scope is there, we can still improve. But yes, again, data is lacking. That's why everybody can have a debate. Neurotherapist Proton has reported from MD Anderson that his incidence rate of ORM is 2%. Or how many protons are there in our country? Only one. That too is not running. Honestly speaking, Chennai is struggling for it. The problem comes when a re-radiation comes. We have already treated 5% ORN, and out of that, we have to treat again. It's a hell lot of situation. The cumulative mandible dose exceeds many times 100 gray, but fortunately they do develop ORN. So we try to save with our treatments. And fortunately, Baroda has a hyperbaric oxygen therapy unit. They have a good surgeon so that we can do the resection. So fortunately, we had a good dentist who will still keep the follow-up and do the conservative management. What we expect from this patient, treated in 2017, this side, right side, and again recurrence on the left side, surgery done, and recurrence has happened in all over the flap. What we expect from this patient? ORN. But we have to save the life. That's the only thing. Only what we can do is how to prevent it. So Dr. Srinivas has already included all this. Important thing is how to diagnose ORN from the tumor recurrence. It's a very simple thing. There is a soft tissue mass, chances of recurrence is there, get the biopsy. If it is this kind of thing, soft tissue mass, don't do the biopsy, you straightforward start the treatment. There is no consensus on the imaging based on imaging-based screening of the ORN. But this is very important. This is now coming that if your mandible has exposed with so many doses, please inform your surgeon and dentist that this patient is likely to have an ORN. So be careful about this patient. Everywhere in the oncology practice, it is very clearly written the patient has to be examined at least in the 6 months. If nobody is, consultants are not following, it is their error. And we should not make the patient as a commodity. There's I already listed in the practice guideline what to do with the dental. This is having 2-page so many details about dental. So many treatments are available. Dr. Srinivas has already included that. This is the example of the same hyperbaric oxygen patient therapy. But there is a debate actually. Unfortunately, data is not that convincing. So I think Dr. Oja is going to take care of that. And what I understand is whenever there is a ORN established, we always ask the patient to see our surgeon so that if they can do best for him. But again, if I have done a recent survey, I realized that the surgeons are not still happy with managing the ORN because of the still further failures. But that's a thing which we need to evolve, to keep on evolving ourselves so that how we can manage this kind of situation. There are so many ongoing trials. I'll stop my talk. And my focus is very clear in this. We are creating this kind of iatrogenic issues, but to save the life of the patient, and we have saved a lot. But question is that we need to respect the dentist because they are important key person who can save us from this kind of side effects. And that too, not only during treatment, after treatment also this is required. This is required for the diagnosis of earlier patients, diagnosis of recurrences much earlier stage. And that's very important. And thank you all for giving me opportunity to have a wonderful talk. Thank you. Hello.
Hello.
I'm audible?
Yes. Say something?
No,
Thank you,
that's
Dr. Ashish. Thank you, Dr. Ashish Kumar, for very nice presentation, very informative, and very nicely taken recurrence and re-radiate. Now, Dr. Chairperson remark from Dr. Dhiren Srivastava, please. Yes, sir.
Thanks, Dr. Nathani. So after the lecture of Dr. Ashish and Dr. Shri Nawaz, what I will say is that we have to weigh life versus osteoradionecrosis, and definitely the life is more important as most of the data is suggested, and Dr. Ashish Kumar talk was very lucid and very good for this purpose. And but what I will say that as Dr. Ashish has pointed out, if all the cases of where we are going to have radiotherapy, they are referred to the dental surgeons and they are taking care and they are compliant, at least we can save osteoradionecrosis to a marked extent. And second thing I would like to add in this is that if we are doing targeted radiotherapy, we can there are further chance that we will reduce the chances of osteoradionecrosis. With this, I would like to thank Dr. Ashish and Dr. for their.
Thank you, Thank you so much, Dr. Dhiren.
Thanks, Dr. Nathani, and thanks the organizers for giving me this opportunity to have with all of you. Thank you very much.
Thank you so much, sir, for giving your precious time. And it is very clear that the dental attention for the head and neck patient is essential and must be incorporated in each stage of oncological procedure. Now, the moderator for the scientific session 3, 4, and 5 is Dr. Sumant Bholu. Sir has done his educational, the qualification, the MBBS, MS ENT from AIMS New Delhi. He is a fellow in surgery, MCH in head and neck surgery and oncology, AIMS New Delhi. His areas of interest are head and neck oncology, reconstruction, airway surgery, skull-based surgery, transoral robotic surgery, and rehabilitations. He is a member of FHNO, AOI, Association of Phonosurgery and Oncology Forum. He's a fellowship coordinator at MICC. So for the scientific session 3, 4, and 5, over to Dr. Sumant.
Thank you, Dr. Keshav. Thanks for the warm welcome, and I would like to congratulate Dr. Srinivas and Ashish for the excellent presentation. So good afternoon to all the faculty and delegates. I would like to thank ICanCaRe Foundation, Dr. Pavan, Shruti, for the entire team for the amount of the efforts they put for this E-Conclave success and during the pre and the post sessions also. I would like to congratulate you and have best wishes for the next coming sessions also. The topic for the sessions is like capacity building and including the dental and oral pathologists in the part of multidisciplinary approach. Head and neck management, carcinomas management is mostly a multidisciplinary and it is followed in universal as a protocol. And the involvement of the dental surgeons and the oral pathologists plays a very vital role in each and every part of the treatment, right from the pre to post-op. So, and it has been emphasized clearly in the NCCN guidelines, what is the role and what is the protocols for the follow-ups and the pre-treatment protocols also. So with this, I would like to start with the continuation as a part of continuation for the next couple sessions, which is dose for hyperbaric oxygen therapy. Does it works? So I would like to invite the Shapen for this session. Dr. Ranjit Kumar, he's ex-professor, head department of high altitude physiology and hyperbaric medicine in the Institute of Aeromedicine, Bangalore. He's been associated with the high altitude physiology and hyperbaric medicine since 1974, and he has trained doctors in Air Force and various armed forces. He's also a consultant in Casco Industries, Pune, for hyperbaric chambers and high altitude chambers for training of aviators. He's also consultant at ASMD and GmbH Austria, a company which is specialized in manufacturing and high-end equipment for high altitude trainings. And I would like to invite our speaker, Dr. Sandeep Ahuja. He's also director Jayashree Hospitals, Gujarat. He's a consultant physician and diabetologist, and he's an innovator and he's an educator on advanced wound care modalities and the use of hyperbaric oxygen therapy in wounds. He's also a member of Undersea Hyperbaric Medicine Society, USA, and he's also been a founder of a member of Wound Care and Hyperbaric Medicine Society, India. He's also holding a position of director of Jayashree Hospitals and ICUs. So I'd like to ask Dr. Sandeep to share the screen.
Very good afternoon. Okay, it's very nice to hear that everybody, because I'm doing this therapy since very long, and starting with this therapy, it was somewhat disappointed that, like Dr. Srinivasan said, that it is not availability is the issue, not the availability, actually the cost is the issue. And I would like to answer Dr. Ashish Kumar also through this presentation that this therapy does work, and eventually we will see what mistakes we may be doing in treating patients adjuvantly with hyperbaric therapy. So our objective is to know what is hyperbaric therapy, what is the chamber, what kind of chamber is there, mechanism of action, role of hyperbaric therapy in ORN, it has been talked about, the protocol, Mark's protocol, case studies and contraindication, which we need to know, and safety in oncology. Every oncologist, they ask me this. So these are the peri chambers, 4-chamber in US setup is there. So what is an hyperbaric oxygen therapy? So hyperbaric oxygen therapy, if you go by physiological definition, if you give oxygen greater than atmospheric pressure to treat basic disease and processes, so it is called hyperbaric therapy. So two things are important, hyper and baric. So with high pressure, if we are giving oxygen, then it is called hyperbaric therapy. So oxygen is considered as a drug, but it is not like another drug. So definition of HBOT, why I have included 1.5 or higher? Because it is more important in healing the wound. So we are talking about the pressure. Why we are talking about the pressure? Because of the next slides, I will go through it. And oxygen should be received by inhalation only. So placing an extremity in a topical oxygen chamber is not an hyperbaric therapy. There are so many sham therapies is now coming out. So you require to be your entire body inside a chamber, then it is called hyperbaric therapy. So these therapies, topical therapies, is not going to help in hyperbaric therapy. Even those soft chambers, which are not being pressurized more than 1.5, less than 1.5, they are also not going to act as a hyperbaric therapy. So as per US guidelines, they classify as a multiplace chamber, monoplace chamber, and animal chambers. So this is typical hyperbaric therapy, monoplace chamber, where patient can sit, and like Dr. Ashish shared one of this peri chamber in Baroda. So these are monoplace chamber, and these are multiplace chamber. They are bulky, heavy, but advantages is many patients can take oxygen in one chamber. So these are the comparison of chamber. So what hyperbaric therapy do? What hyperoxygenation causes? So immune stimulation is done, neovascularization is done, vasoconstriction is done to reduce the edema or tissue swelling. It has a bactericidal effect. It reduces half-life of carboxyhemoglobin in carbon monoxide poisoning. It has also a mechanical effect. So it is a bubble theory. When a bubble is reduced because of the compression, so it is used in air embolism and decompression sickness. Reactivates sleeping sickness, so it is sleeping cells. So in the penumbra region, you can even use in neurological conditions. Studies still on, it is debatable, but we have seen the results. So these are the therapeutic use, and these are the what hyperbaric therapy can do in your body. So as we talked about, pressure should be 1.5 and higher, but what are the protocols? So pressurization, typically in osteoradionecrosis, I will talk about, it is 2 or 2.4 ATA, receives oxygen by inhalation, either by mask. You saw in multiplace chamber, there is a hood, or by ambience in a monoplace chamber. An exposure time of 60 to 90 or even 120 minutes is the protocol. So there are permutation combination of protocols. You can go with it. So basically, why we are giving hyperbaric therapy? So we know that if tissue oxygenation, TCPO2 is below 30 degree, any wound is not going to heal. That's why we need to give hyperbaric therapy. And what if there is no vascularization? How oxygen reach to the wound or to the tissue? So that's why hyperbaric therapy comes in. I'll just pass this slide and go through that. Even hyperbaric therapy is established that it enhances your stem cells. So if you can see that pre-treatment, one treatment, after 20 treatments, you can see how much stimulation of stem cells is being done in CT. So actually, why I'm showing this, you will see in the next slide. Actually, everything depends on how much treatment you are going and how you are giving this treatment. So this is pre-HbO2. this is platelet-derived growth factors. This is pre, and this is post. You can see these are the evidences which I am showing you. So here, it is a very good slide. You can see that when your tissue oxygenation is here 30, TCPO2 is 30 and or less, then tissue healing is gap. And this is the normal tissue which you see. So the time you are giving, the number of sessions you are giving, so after 16 to 20 sittings, which I say typically, you start seeing the results. And even if after completing 40 sittings, you can see over the years, the TCPO2 doesn't decrease in given hyperbaric therapy patients. So why this is important? What protocol we need to see? So 2% volume increases the each atmosphere. So there is a gas bubble theory. I have not covered mechanism of action, but we know when some partial pressure of any gas is increased above the liquid, this gas dissolves into that liquid. So this is the effect of soda bottle, which we can say. So that's how the oxygen dissolved into plasma and goes everywhere. So how much more oxygen is dissolved, it depends into the protocol, and how much more oxygen, more the pressure, more oxygen dissolved. But we need to see and identify oxygen toxicity. That's why we go typically up to 2.4 atmospheric pressure. And if you are giving for 90 minutes or more, we have to give a air breath. So this is how during the therapy, you see oxygen in the blood, in the muscles and subcutaneous tissue. This is the main slide because of which we may have failure of hyperbaric therapy if you are not following this protocol. So you can see if you are going one treatment, so you have 20 mm of HGTCPO2, given one treatment 1400, next day when patients come again another 2022, then another day again you pure rises and give this. So because of this, tissue oxygenation increase slow by slow. So at least if you give 16 to 20 treatments, you are not going to get a good effect of hyperbaric therapy. Otherwise, what happened? 10 treatments, 15 treatments, the constraints are not availability, the constraints are money. After giving surgeries, after having treatment for cancers, and after giving radiation therapy, when patient comes to us for hyperbaric therapy, they don't have money. So in private, it is very difficult to treat patients. So it is an expensive modality to establish in every center. So government centers are less, and private center, it is expensive. So this is what happens. This is normal. You see restricted blood flow. And when you give hyperbaric oxygen therapy, all tissue is embedded with oxygen and angiogenesis occurs. So what are the indications? I'll go through fast through these indications: air, gas embolism, arterial insufficiencies. So in similar central Lateral artery occlusion, selected wound problems, carbon monoxide poisoning, gas gangrene, compromised grafts and flaps, acute traumatic ischemias, decompression sickness, delayed radiation injuries, sudden sensory neural hearing loss, intracranial abscess, necrotizing soft tissue infections, refractory osteomyelitis, and severe anemia. But we need to see these are the indication which is approved by FDA in US, and there are other treatments also we use hyperbaric therapy, which are called off-label indication of hyperbaric therapy. So in oncology, most of the time we see management of radionecrosis in most commonly in mandible necrosis. Soft tissue necrosis like laryngeal, head and neck, and chest wall necrosis or extremities also we can use. Radiation cystitis, very good results in radiation cystitis, proctitis, and enteritis, or abdominal pelvic injury also. Radiation-induced optic neuropathy, radiation-induced retinopathy, vesicocutaneous fistula, and in central nervous system also. So it can be used as adjunctive therapy to the radiation also. There has been done because we know all tumors are hypoxic in nature. If you see that it is not sensitive, you can go by lower the dose and start adjuvant treatment with hyperbaric therapy. There have been studies done on that. Then it is a sensitizer also in neuroblastoma, glioblastoma, astrocytomas, and or in most cases of re-radiation also, we have given adjuvant hyperbaric therapy. Within 90 minutes, you straight away give radiation therapy, and very less even soft tissue injuries after giving hyperbaric therapy adjuvant to in re-radiation, only in re-radiation patients. There are good effects. So safety is the major concern, which everybody says that it improves angiogenesis. So what if it is going to again stimulate tumor growth in any tissue, and we have a reoccurrence in patients? So it does hyperbaric oxygen does angiogenesis. Most of the thing it is non-healing hypoxic wound. It is, and it definitely the pathology and the there are definitely difference when you go for hyperbaric therapy, angiogenesis, and other angiogenesis. There is over 3,000 papers which says that it is safe for hyperbaric therapy is safe, and no, it has neutral effect or cancer inhibitory effect on any tumor. In US, 50% of all patients treated, it is most of them are osteoradionecrosis patients. So whatever that chunk of patients they are treating every day, 50% of hyperbaric therapy patients are ORN patients or some kind of radiation injury patients. So this has been, you already know that hypoxic hypovascular theory of Marx and how to use this. So actually Marx, he thought that microorganism plays only a contamination role in ORN. And actually because of this 3H is the major problem with that. And this is how he established his theory has been, and protocol has been established. Actually, when we started, we have to go for hyperbaric therapy, 20 treatments, 30 treatments, 20 plus 30, 30 plus 40. So how to go about it? That we can have a better result. And in his studies, he showed there are 100% results in hyperbaric therapy. So let's see in stage 1 Max protocol. Stage 1 protocols, consecutive everyday treatment, 30 treatments at 2.4 atmospheric pressure for 90 minutes. If you see clinical improvement, go for 10 more. Or if you, and then if wound is healed, okay. But after 3 months, the wound is not healing, then this is at least advanced to stage 2. So again, we have to tell our surgeons to be bold and go in local debridement. I have seen when I ask them that this is a failure of stage 2 patients, you have to go for a debridement. They don't want to touch the patient because we don't want to make it worse. We are in a private practice. It is a difficult thing to do, to make patient worse. So they don't debride it. If you are not debriding it, it is not going to have a good result if it is a stage 2. So you can give 10 treatments or 20 treatments. So total of 60 treatments. It is still safe. Doesn't matter. No oxygen toxicity will happen. But if you see wound dehiscence or failure to heal, these patients go to stage 3. In stage 3 criteria, again, you have to go for hyperbaric therapy. Then after it is not healing, go for partial jaw resection. Then again, the 10 treatments. If again failure, go for bony reconstruction. But every step you go for a 10 treatments. If you have given initially 30 treatment of hyperbaric therapy, you can go 10 after each reconstruction and jaw fixation and whatever you are going to do in this patient. This is what shows if you are not following this protocol, there is going to happen a failure in this therapy, this protocol. So hyperbaric therapy stimulates angiogenesis, increase vascular density in rabbit mandible. So this is the model which Marx presented at that time, the initial slides of his. I have got the pictures. So you can say you start giving the therapy and you can see angiogenesis occurring in that patient. So oxygen gradient and how it improves after giving the treatment. So few case studies, not all case studies. I'll just go through by the photographs, so not to take too much of time. So not osteoradionecrosis, just therapy, hyperbaric therapy works or not. So you can see these are the photographs which you have in crush injury. You can see improvements. You can see improvement in diabetic foot patients, non-healing wound patients, venous ulcer patients. You can go and see the improvement. Photographs and healed patients speaks a lot of them. But still we need to see if this is, you are, even in this foot also, you are going to give hypertherapy, this is not going to work. Debridement combination with hyperbaric therapy, then only it is going to work. The tissue which is dead, it is dead. It is not going to revive by hyperbaric therapy. We need to understand this. And this is how anything will heal, and you will see effect of hyperbaric therapy in ORN or radiation tissue injury in patients. So another thing is, which I'll like to cover, is contraindication and indications. I'll go fast through this. So there are absolute contraindication. If it is, or the only actually absolute contraindication is untreated pneumothorax. So you need to put a chest tube and then you can treat the patient. In oncology, you need to be careful of these drugs, doxorubicin, cisplatinum, disulfiram, mefenide acetate. And there are relative contraindication. Asthma, chronic sinusitis, if patient is coming to you with some infection, 3 treatments he has already taken, then also we need to treat. If he is having fever, we don't put that patient inside the chamber. We don't need to lower the fever also. In pacemaker, if patient is having a pacemaker, we can still give. We need to contact the manufacturer, get the safety level, what kind of, nowadays pacemaker is coming, which is 380 and more. So they are safe to take inside the chamber. So in conclusion, we can say that hyperbaric therapy works. I have not included studies because it would have become a very big presentation, but still hyperbaric therapy works. And it is very safe to give in malignancy. And even though now studies are coming up of adjuvant with radiotherapy, you can give hyperbaric therapy. So whatever is that not availability, the cost is the issue. Many existing hyperbaric centers are struggling only because of the cost. Only because of the cost of the therapy, they cannot lower it down. The chambers which are there, you have to be safe for use in patients, and not to have any chambers like sir who is certified. He can certify this is a safe chamber. If something happens in this patient happens inside the chamber, this is going to be the fault. So that's why we need to have protocols for hyperbaric also. And if you are going to establish these protocols and follow all the guidelines, any chamber, multiplex chamber or monoplex chambers, it is going to be little expensive. So this is not availability expensive. It is not available because of the cost, actually. Okay, thank you very much.
Thank you very much. Waiting for chairman's remark, Dr. Ranjit.
We can't hear you.
Sir, we would like to have your remarks, Dr.
Ranjit,
your remarks for the talk, sir.
I'm coming, madam. Well, I must compliment doctor. It's a fantastic presentation in a very short time. It's covered right from physiology, then contraindication, indication, and what all more. Everything here covered in a very short time. And I've been using hyperbaric oxygenation from 1974 onwards. And I installed many chambers in the country and also abroad, like Vietnam and Myanmar and other places. I trained the doctors over there. But I think Dr. Sandeep, you have done a fantastic job, and I don't want to say anything more. And regarding availability of chamber, the chamber are now manufactured in India, and they are much cheaper than what you will buy from outside. Okay, so you don't have to go for say chamber made in USA or made in anywhere else. Our chambers are as good, and they're all certified to the stringent specification made by any part of the world. But I have nothing much to add, actually. You didn't mention something about oxygen toxicity, which is a very ill-understood topic, very ill understood. Oxygen toxicity takes place only, it's a dose and duration relation phenomenon. When we talk of dose, it means what is the pressure of oxygen and duration, of course. So if it is more than 2.5 atmospheres for more than 2 hours, in most of the cases, there may be very mild oxygen toxicity, which are two kinds. One is neurological, other is pulmonary toxicity. But anyway, these are not required in our normal cases. We don't go to that duration that is more than 2 hours and 2.5 atmosphere. The indication for that is a very few. That is like decompression sickness of the divers or decompression sickness of the aviators. These are the only places where you have to go. And of course, we take all the risk and chances and precautions so that it doesn't happen. And I think in a short while, Dr. Sandeep Puja has done a fantastic job of introducing the subject to the people. I will have nothing more to add. I think he's covered almost all the aspects. Thank you. Thank you, Dr. Puja.
Thank you very much, sir. With this, we are going to start our next session, which is one of the very pestering issue for both the patient and for the oncological caregiver and for the patient family members also, even from the pre-op towards the post-op rehabilitation, which is the Christmas, and which is one of the unique characteristics which is related to the South Asian countries because of the tobacco chewing or because of the oral submucosal fibrosis. So we're looking forward for excellent talk. For this, I would like to invite Chairperson Dr. S.K. Kataria. He's a professor and head of the Department of Dental Surgery in SN Medical College, Agra. He's also an executive committee member of Dental Council of India and the member of board of governors of Uttar Pradesh University of Medical Sciences. And he's also published in numerous number of research papers and chaired many scientific sessions in national and international conference. I would like to welcome Dr. S.K. Kataria. For this session, I would like to invite our speaker, Dr. Neeti Kapre. She is a consultant and head and neck surgeon, Neeti Clinic, Nagpur. She did MBBS and DNB in otorhinology from KEM, Mumbai, which is a prestigious institution in India. And she has numerous publications and numerous fellowships. And one of them is the very affiliated clinical fellowship from TMH and from the Golf Fellowship also. So I would like to invite Dr. Neeti Kapre to stay in the session. Thank you.
Okay. Yeah, can you enable me to screen share, please?
Pratik, can you? Yes, ma'am. Done. You can share the screen now.
Sure. Thank you so much and a very good afternoon to everyone. So my brief today is to speak on the surgical management of trismus, and I think my candidature was prompted by my place of practice, because Vidarbha is proudly the tiger capital, but shamefully also the OSMF capital of India. Surgery for benign OSMF related trismus is recommended for grades 3 and 4A. And in the interest of time, I'm going to cut to the chase. So surgical procedure, for those of you not familiar, steps include excision of fibrotic bands, ancillary procedures such as myotomies of the masseter, medial pterygoid and temporalis muscles, coronoidectomy, and last molar extractions. Of course, complemented with a vascularized soft tissue reconstruction. Before we head on to the surgical video, let me share a brief word on instrumentation. So visualization is a big problem during trismus surgery, and that's why we've devised this double lumen instrument. So on one end, there's a suction channel, and on the other, there's a fiber optic cable to allow us to see in bloody and problematic areas. These are again two long bladed right angle retractors. So the one on the lateral side retracts the masseter away from the mandible, and the one with the notch rides onto the coronoid. Surgery begins with identification of the fibrotic bands. So the anterior mucosal cut, as we say, is to release the labial and the anterior buccal mucosal bands. We are using CO2 laser here, but cold steel, electrocautery, any thermal energy device is acceptable.
And this is now what we call the posterior mucosal cut. So it's in the form of actually a sleeping T. The vertical component is along the anterior border of the ascending ramus of the mandible, and the horizontal component is goes right across the RMT and sometimes even across the soft palate, depending upon, of course, the severity of the trismus. Steps in trismus surgery are often done in tandem. So after one side is done, you would pack that area with saline adrenaline soaked gauze pieces to afford hemostasis and to take away, sorry, to take away the laser char. And then we would come back to that area. So here you can see the opposite side posterior mucosal cut being made. And most often surgeons would stop just at this, because even this will actually afford an increase in the interincisor distance by roughly 2 to 2.5 centimeters. But if you want to do anything better than that, myotomies and coronoidectomies are a must. So this is an endoscopic picture, and as you can see, the medial pterygoid muscle and the temporalis muscle are being released, and the coronoid is being bared. Mind you, if we don't do this well, we're doing this with an angle tip cautery, and unless all the muscular attachments are completely bared off the coronoid and we start doing a coronoidectomy, the tip will kind of just flow off into the ITF, and then retrieving it is an extremely bloody and messy affair. So once we're sure that the bone is completely bare, we will then initiate an osteotomy. We're doing this with a fissured burr here. So roughly 3 to 5 millimeters above the sigmoid notch. And then we'll complete the coronoidectomy with a chisel and a hammer. Again, we would like to hold on to the tip of the coronoid process with a Cocker's or an Ali's forceps. The rough edges of the bone can then be drilled out using a diamond or a round burr, and these are the extractions on both sides. And that's the interincisor distance. The procedure is completed only after identification and, if required, immediate correction of any temporomandibular dislocation, if any. So we've done roughly 372 procedures so far. And for the past decade or so, our reconstruction of choice has been the palatal or the platysmal flap. The platysma is a myocutaneous flap situated between the midline medially and the external jugular vein laterally. Size of the flap, of course, depends on the size of the defect, but roughly a 5 by 3 centimeters flap generally suffices. We're now raising the flap in the subplatysmal plane. The external jugular vein is ligated below so that it affords a good venous drainage and avoids any decongestion of the flap. A paramandibular tunnel is then created and the flap is delivered intraorally. These tag sutures that we take allow for the flap deliverance without any undue torsion or twist onto the flap. And that's the flap inset. And that's the final picture. The advantage of this flap is it's a remote scar which is well hidden within the collar incision, collar area, and so does not cause a cosmetic problem to the patient as in the other nasolabial, etc. flaps. So we found in our analysis that predictors for surgical outcomes have been performance of coronoidectomy, type of reconstruction, and of course, physiotherapy compliance. But when we talk of trismus in the presence of oral cancer, apart from the pre-existing OSMF, it could be due to tumor directly infiltrating the masticator space. It could be surgical resection induced, radiation induced, disuse atrophy and demineralization, or just afferent pain causing an efferent increase in the masticator muscle tone or reflectory trismus. So how does one try and deal with this? Now, as far as prevalence is concerned, in our patient population, it can be as high as 70%. This is the Tata paper, whereas world over, it is anywhere between 20 to 80. Of course, primary reasons are we deal a lot with GB sulcus cancers, And of course, prevalence of pre-existing OSMF largely contributes. Now, be it what may, the etiology, but once trismus sets in, even the bravest of surgeons don't want to hold the bull by its horn. So the superior method actually is prevention. Prevention preoperatively through good assessment and counseling, intraoperatively through certain surgical adjuncts I will be alluding to further, and postoperatively through better radiation delivery techniques. Now we know that radiation-induced trismus is because of the deliverance of certain dosages to the masticator muscles, which are practically inevitable if you want to treat properly an oral cancer in the adjuvant setting. So IMRT and IGRT do help in reducing the incidence, but even within that subset, patients at risk of developing trismus are those who had a worse pre-radiation mouth opening. So again, putting the onus squarely on the surgeon, that there's something we might be able to do during surgery itself. Of course, not leaving behind any devitalized muscle or soft tissue, doing a good vascularized, adequate reconstruction, but maybe something more. So this is a very small study, just 36 oral cancer patients undergoing marginal mandibulectomy. But just an additional ipsilateral coronoidectomy and myotomy significantly improved trismus results. So whenever a marginal is being done, always do an ipsilateral coronoidectomy along with it. What we recommend at our center is a step bolder. We do contralateral trismus release at the same setting. So there's a background oral submucous fibrosis and there is a cancer on the ipsilateral side. After resection of the primary and a good sterilization of the field, we would do a trismus release operation on the contralateral side, steps of which of course will be the same like in the video. To begin with, there was some debate about the oncological safety of this procedure. We surely don't recommend it in the setting of field cancerization or already presence of potentially malignant conditions on the contralateral side. But barring that, we have found this to be an extremely safe surgery. We've done nearly 100 patients so far. Almost half of them were bialveolar resections. So as you can see, there's a left-sided buccal composite resection done and a right-sided trismus release on the contralateral side, that is, and reconstructed with a hemipalatal flap. Equal numbers were reconstructed with free and pedicle flap surgeries, and almost all required adjuvant radiation. Of 83 evaluable patients, 68% had consistently improved mouth opening with a contralateral trismus release, an average IID of 3.2 centimeters. Again, predictors of success were site of the primary, adjuvant treatment, reconstruction, and physiotherapy compliance. Now, to aid the last point, we insist on good pain control early on. So we give mandibular nerve blocks on day 2, 5, 7, and 14 after surgery on the contralateral trismus release side to initiate and encourage early and aggressive physiotherapy in the post-op period and continually through the adjuvant treatment as well. Because this really is the make or break factor. And I'm so happy that Dr. Anurag is going to tell us more. And TrisCare is such a wonderful device. And that's really the beauty of this program, that there is comprehensive discussion towards betterment of oral cancer care. Because hand to our hearts, all of us physicians, at the end of the day, kind of rub the magic lamp genie and ask him for our patients to have good disease-free survival, good quality of life outcomes, and hopefully, just hopefully, a mouth opening something like this. Thank you very much. For those interested, this is the only surgical atlas actually available on trismus surgery. And my mentors, Dr. Kapre and Kothe, are the editors. It's freely available online as well as on Amazon. Thank you again for ICanCaRe for this lovely academic initiative and the opportunity to speak.
Really excellent presentation, madam, you have given. And as you rightly said, other speaker also said that trismus should be prevented from the beginning. Excellent procedures with minimum discomfort to the patients. Always there should be multidisciplinary team approach. And I have seen the patients actually who comes very late with almost zero mouth opening. Very difficult to even take the food and water. So excellent procedures. Thank you very much for the excellent presentation. Very nice. Very good.
Thank you so much, sir.
Dr. Shruti, can I say something?
Yeah, sure, sir. Please go ahead.
Yeah, Dr. Neeti, thanks for very nice presentation. Actually, in our center in ESIC Dental College in Rohini, Delhi, we are doing submucous fibrosis with the same technique, or we are doing unilateral, ipsilateral coronoidectomy, bilateral coronoidectomy, everything is the same. But instead of putting platysma or pharyngeal or palatal graft, we are doing buccal fat pad graft, and it has got excellent results even if you do buccal fat pad graft. The idea of giving buccal fat pad graft is that there is no second incision is given. You can take out you can mobilize the buccal fat graft from the same incision, and in addition to this, there is no extraoral scar. So I would recommend that you should also start trying doing buccal fat pad graft. It gives excellent results with the same technique.
So, sir, thank you, and point well taken. So we've actually tried everything in the book, from tongue flaps to, like you rightly said, a buccal fat pad, nasolabials, mandibular mucoperiosteal flap. Maybe our experience with buccal fat pad, it might not be as extensive as yours. Somehow the platysma and the palatal work best in our kind of hands, but surely, absolutely, sir, I agree with you.
Thank you. Thank you very much. Thank you.
Thank you very much.
Thank you so much. I think this was another fantastic technical session where we learned about the surgical management of trismus. Now we move ahead to the next scientific session where we're talking about the mechanical management of trismus. So for this session, we were supposed to have Dr. Surendra Dabas and Dr. Anurag Yadav as the chairperson and speaker respectively. However, due to some emergency, they're not here with us today and would be represented by other members, Dr. Pawan and Dr. Harshita and team. So here I'll quickly request Somesh sir, if you're there with us, I request you sir to please put on the video. We're going to launch this video here, and I'm very proud to share that this is a device which is researched in collaboration with Gujarat University by ICanCaRe and has been designed for the Indian subcontinent. Very nice and a sturdy product for trismus management mechanically. So, sir, I'm going to hand you the remote control, Somesh sir. Kindly please accept the remote control, and you need to press the inaugurate button once. So we can't hear you, you're mute.
Where do I get the remote button?
So you are now controlling my screen, so you just have to press the inaugurate button once.
Where's that?
So down, if you can see the red button, sir, the inaugurate button.
Oh, just a moment, I must see.
So I'll bring you to the button here.
Yeah, now I see it.
Yeah. Thank you so much, sir. I'm going to quickly play the video which we have for this device so that we know what is this device. I think my laptop is hung. I'm so sorry for the inconvenience. It seems my laptop is hung. that is a Triscare video, which we have designed shortly to talk about the device. I now invite Dr. Harshita Pandey. She is the certified tobacco cessation specialist from Gujarat University and also a dental practitioner who's working at the ICanCaRe Tobacco Cessation and Oral Screening Center at Max Vaishali. So Harshita, over to you to please talk about the device.
Very fine. Good evening, everyone. Thank you so much, Dr. Pawan sir, Shruti ma'am, for giving me this opportunity to say a few words about our this device, Triscare. So, Triscare oral mouth opening device by ICanCaRe is exclusively launched to increase the mouth opening of the patients. It's a completely jaw motion rehab system. It has orofacial muscle exerciser. It opens jaw to stretch orofacial muscles and mobilize temporomandibular. So it is very easy to use and easy to carry. I have been using this device from a very long time in my patients in Max, and I have seen tremendous results in my patients. So it is for the patients who have this OSMF problem, post-dental procedure problem, post-radiation to head and neck surgeries, post-surgeries, and pre and post-operative oral surgeries. So this device, the best thing about this device, which I liked, is the measuring scale, which shows the current mouth opening of the patient, and patient can see the difference within a week after a regular use. So now I would like to call the man who has invented this device. So these are Dr. Pawan sir. Over to you, Pawan sir.
Well, thank you, Harshita. Thank you, Shruti. Thank you, Niti. And most importantly, thanks, Dr. Shomesh, for inaugurating this video and giving opportunity to launch this device across India. I just saw a message in the chat box that it can break the teeth and or the device can break. The fact is that this device has been made with this special material, POP material, and which does not break. POM material is a polyoxymethylene polymer. It has got a very high resistance. It does not break, and because of its tensile strength, it does not break the teeth also. So this is one thing that we as a surgical oncologist and we as radiation oncologist or we as a dental surgeon, we needed something that would help our patients to improve the mouth opening. We had been using a lot of materials, which was like the ice cream stick which Niti showed in her last picture. And then we also were using certain other materials which were quite costly, which were being imported. We needed something, Indian answer to the Indian problem. The submucosal fibrosis, almost 13 crore people having the submucosal fibrosis in India. They needed some sort of answer to which was cheaper and which could be easily available across India. So this is a device, I think everyone would agree. I don't think there needs to be a presentation on saying that a mechanical mouth opening is a must. And I'm sure Niti would agree that even after whatever surgeries one does, even Dr. Srivastava, even if you put a buccal pad fat, which I have been also using, you definitely need a device to keep the mouth opening. So this is the device. And I thank you for giving this opportunity to launch this device on this platform. And I think we should go ahead. Thank you so much. And if Dr. Shomesh, my boss, my mentor, if he has a few words to say about it. Dr. Shomesh, over to you. I think Shruti, let's go ahead. Dr. at the end. So let's go ahead.
Okay, thank you so much, sir, for talking about the wonderful product Triscare. It's available, and I'm going to post down the link so that all of you can have a look at the device, see the video, and also know about this device. So we move ahead. Now we have finished with the technical sessions for the day, and now we are moving ahead with the panel discussion. It's a very interesting panel discussion because we have the theme on synergistic care, which is interdisciplinary versus multidisciplinary care, and how oncologists have to collaborate with a dental specialist for better outcome and quality of life in patients. For this panel discussion, I would like to invite moderator for the evening, Dr. Abhishek Vaidya, sir is consultant of head and neck surgery from National Cancer Institute, Nagpur, and assistant professor, from ENT, head and neck from NKP SIMS Nagpur. His area of interest include thyroid surgery, skull-based surgery, endoscopic sinus and skull-based surgery, laryngeal surgery. He also has International FHNO's Fellowship, MSKCC New York, has authored 5 book chapters, including 2 on thyroid, and is a prolific oncosurgeon himself. So I invite sir to take the panel discussion ahead.
Thank you so very much. Thank you so much, Dr. Pawan sir, for this unique initiative. ICanCaRe is an amazing initiative, and the theme for today is kind of a it's self-explanatory, but it's also very intuitive. When you look at oral cancers, you have to have a team which will carry the treatment forward so that rehabilitation and getting back to life is optimum. So this is that panel. For the panel, may I invite as chairpersons respected Dr. A.K. Dewan sir and respected Dr. Anusuya Sharma ma'am. Let me quickly introduce them. Dr. Dewan sir is a director of surgical oncology at Rajiv Gandhi Cancer Institute. He's a leading surgical oncologist with more than 30 years of experience. His areas of interest are head and neck and breast and cancer surgery. He conducts numerous major and minor cancers every month and has conducted more than 18,000 surgeries over his richly experienced career. He's the chief editor of the Rajiv Gandhi Cancer Institute monthly newsletter, several articles to his credit, and he practices evidence-based medicine with emphasis on multimodal approach. His motto is to treat my patient as I would want myself to be treated, and with care and passion. Also, may I invite Dr. Anusuya Sharma ma'am. She's the HOD Department of Dentistry, Max Super Specialty Hospital at Patparganj. Extensive experience in this field of more than 30 years. Her surgical and clinical expertise covers the entire spectrum of dental and oral diseases. She loves teaching her specialty and is associated with the Sharda University for teaching postgraduate students in oral and maxillofacial surgery. She has several publications to her credit in national as well as international journals. And she has been the professor and head of Department of Oral and Maxillofacial Surgery at Sharda University till 2018. Welcome, sir and ma'am. May I also invite our panelists. We have a rich panel here. We have Dr. Dinesh Singh, who is senior director at Max Super Specialty Hospital, Vaishali and Patparganj. Dr. Kinjal Jani, who is a director and head, Department of Radiation Oncology at HCG Cancer Center, Ahmedabad. Dr. Rahul Thakur, director of Shubheksha Multi-Speciality Hospital, Vadodara. Dr. Kapila Manikantan, consultant head and neck surgery at Tata Medical Center, Kolkata. Dr. Ashutosh Vatsayan, consultant in Department of Maxillofacial, Oral Cancer and Reconstructive Surgery at NemCare Super Speciality Hospital, Guwahati, Assam. And Dr. Deepak Balasubramaniam, clinical associate professor in Department of Head and Neck Surgery at Amrita, Kochi. So welcome to all the panelists. Also joining in our panel are Dr. Mitali Dandekar, consultant head and neck surgical oncologist at Paras Cancer Center and Mahavir Cancer Center, Patna. Dr. Jyotika Jain, consultant radiation oncologist, Venkateshwar Hospital, New Delhi. Dr. Vikas Goswami, associate director of medical oncology at MICC East Zone. And Dr. Shiva Manjunathan, academic in charge, professor and head, Department of Periodontics and Implantology, Institute of Dental Sciences. Absolutely rich panel there. We have experts from surgical oncology, we have from medical radiation oncology, and a host of dental specialists. So let me share my screen right away and let's get started. So without further ado, if I may ask any of your panelists to come forward and really explain what you think is the paradigm change in all the specialties collaborating together. What is this whole thing about interdisciplinary versus multidisciplinary? Any of the panelists, Dr. Rahul, Dr. Deepak, any of you, if you can just elaborate how different these two terms are.
So, thank you, Dr. Abhishek. So as this panel name suggests, interdisciplinary versus multidisciplinary, I think the main motto is communication. And as one of my colleagues rightly put, a proper communication, just proper communication can improve at least 10% of the result. So I think a communication without any hesitation in between, different specialties is the key to success, according to me.
Perfect. So what I want to emphasize here that oral cancers are not a unidimensional problem. They are a multidimensional problem. So you have a host of specialists treating them, and this panel is extremely well represented by all of these specialists. What we want is not only individual specialists dealing with the cancer patient, but also the specialists dealing with each other. So it's not just the arrow from the specialist to the patient, from each specialist coming back to the patient and vice versa, but also an intercommunication between all the specialists in every stage of treatment planning, treatment execution, and follow-up. So that is what is really interdisciplinary. What would be multidisciplinary is all of these collaborating, taking individual care of the patient. And while they collaborate, interact with each other, this would be really multidisciplinary. So let me start with a few simple questions. My brief today is to mainly deal with the importance of dental specialists in oral cancer treatment, but let me begin with a few general questions as well. So as we approach oral cancers, may I ask the panelist, who first sees the patient at your center? So may I ask the medical oncologist or the radiation oncologist on the forum to just tell me who first sees the oral cancer patients at your center? Dr. Vikas Goswami, if you could just answer that, sir. Is Dr. Dinesh Singh or Dr. Kunjal Jani here? If they've joined, can they answer that?
Yeah, I'm Dr. Dinesh Singh. What happens at our center that most of the patients, they come with either some pre-reference to a particular specialist. So whenever a person comes with that, whether it is a surgical, radiation, or medical oncologist, the patient is first seen by them. And then this patient is being discussed into the multidisciplinary tumor board. And there we take a decision whether this patient needs to undergo he has to undergo the staging workup, anti-histopathology and the immunohistochemistry studies. And then a combined decision is taken then how to proceed with this treatment. So who sees the patient first? More important than that is before the patient is taken to the treatment, the patient should have been seen by most of the all these specialists or discussed in the this multi-specialty board, and then treatment is taken.
So wonderfully put, sir. It doesn't matter who sees the patient first, as long as adjunct consultations are made for all the patients. Most of your patients go through the pathway of a multidisciplinary tumor board, and all the necessary primary adjunct consultations are done beforehand. So can I ask most of the panelists, do you make all the adjunct consultations for all of your patients before you embark upon your treatment? I'll ask that to surgical oncologists first, and then to radiation and medical oncologists. And the adjunct consultations in this case would include a nutritionist, a psychologist for evaluation, a dental surgeon, a prosthodontist, so on and so forth. So we are referring mainly to oral cancer patients. So if I could ask that to surgical, medical, and radiation oncologists, to all the clinical oncologists first. Dr. Deepak, sir, if you're there. Dr. Mitali. Okay.
So, the points are very well put forth and very rightly put forth. Yes, we must, and most of our patients go for adjunct consultations before undergoing definitive treatment.
Wonderful. So I also want to ask this question. You know, we are sticking to this general theme before we move to specific case scenarios. In your multidisciplinary tumor board, do you often have a dental surgeon or a nutritionist become a part of the treatment? Dr. Kapila, would you want to answer that?
Our multidisciplinary tumor board usually incorporates standard dental surgeon as a nutritionist is also involved. It's also a radiologist, radiation onc, medical oncology. There's also the plastic surgeon who's part of the team. We would discuss all cases before we plan for definitive surgery.
right? So, this is a sentiment echoed by all the panelists here that what we really want to give to the patient, if we want to maximize outcomes, and cure really is not the only outcome. The real outcome would be rehabilitation. And if you want to do that, you should have all the adjunct specialists to be a part of the board right from the beginning. So this is a slightly tricky question. Oral cancers in our country are treated by a wide range of surgeons, and I'm not going to ask this to the surgical oncologist here. Let me put that question to the radiation oncologist and to the medical oncologist. So whom would you want your oral cancer patient going to? Would it be general surgeons or surgical oncologists or ENT surgeons, head and neck oncosurgeons, which is a specialty now, oral maxillofacial surgeons? If I could just put that slightly prickly question to the medical oncologist and to the radiation oncologist. If you were the primary physician seeing that patient, whom would you refer that patient to? Let's say all of these departments are there in your institution. And there's a reason why I'm asking this slightly prickly question. I'll come to that in the next slide. Can I ask Dr. Kinjal Jani or Dr. Vikas Goswami to take that?
Sir, we do not have Dr. Kinjal and Dr. Vikas on the forum.
Okay, so Dr. Dinesh Singh, sir, would you mind taking that question? Dr. Jyotika, may I ask you that question, please?
Yeah, Dr. Abhishek, at our hospital, Max, this situation has been very much simplified by the management. We are having disease management groups. So we have got designated surgeons who are looking after the oral and or the head and neck cancer patients. Okay. So we don't have this much dilemma at our Max.
Okay. Yeah, so the point I wanted to drive home was it does not matter which specialist is treating your surgeon as long as that surgeon has had a good training and a good experience. Specialized surgeons usually have better outcomes than non-specialized surgeons, and outcomes improved after completion of certified training as well as with experienced hands. So it really does not matter who treats your patient as long as they are well qualified, well trained, and they have enough experience. And that really is the crux which I want to drive in today's panel. Adequate training, adequate experience, collaboration, and multi-speciality involvement in oral cancers. Malnutrition is a big problem, and here is a list of conditions which may cause malnutrition: tumor-induced catabolism, mechanical obstruction, pain itself, post-operative, and also adjuvant radiation and toxicity. If we could have some of the panelists just come up and tell me how do they tackle this issue.
Dr. Jyotika, so I'm a radiation oncologist. How
Yes,
exactly? So first of all, any patient who is coming for radiation to us, we take help of dentist, which is practically must for all the patients before taking radiation. And along with that, we tell the patient to see the nutritionist, any dietitian who can explain them what all they are able to take. And if there is some problem with difficulty in swallowing, we take help of gastroenterologist to either put a peg or NG tube, so that initially at the beginning of the treatment, we can ensure the nutrition so that the patient can tolerate radiation well and outcome is better. Okay.
Dr. Jain, ma'am, may I also ask you, would your requirement for nutrition, whether it's added nutrition or whether it's tube placement, would that differ for an adjuvant treatment patient or for an upfront chemoradiation patient? Would that differ?
So that basically depends on what is the location of the tumor. If it is base of the tongue lesion, central lesion, where we are expecting more radiation reactions, and there will be definitely difficulty in swallowing later on. So before starting radiation, like in a first week or second week, we would like to place the NG tube or peg placement, depending upon what is the general status of the patient. Patient is too frail, cannot tolerate NG tube, we prefer peg or otherwise. So depending upon location of the tumor, you decide regarding what way you can support the nutrition.
Okay. May I also ask this question to all the dental specialists in this panel? Is poor nutrition really a problem when you deal with rehabilitation of cancer patients? If any one of you could just
Oh. Okuya. Ekle gua sebenarnya.
There is
Did I
somebody in
just?
between. Can you repeat the question, Abhishek?
I just wanted to know if for prosthetic rehabilitation or post-treatment rehabilitation, is nutrition a big impediment to how you approach your patient?
See, I'm basically a surgeon. I would be referring the patient to the prosthodontist. We don't have a prosthodontist on panel. But
Okay.
what I have noted is a lot of patients of mine want a prosthetic rehab. They feel that the dental rehab is going to make them swallow, and we need to tell them that dysphagia post-radiation is a different issue. A set of teeth is not going to change that. So I think, you know, the enthusiasm for dental rehab also has to be measured and calculated in a post-radiation setting.
Okay, excellently put. And I would agree, you know, dental rehab is not a cure-all for all conditions. We have had lectures about osteoid necrosis and post-treatment trismus. So these can be helped to an extent with rehabilitation, especially prosthetic rehabilitation, but that really is not a cure-all for all of these. So once again, sticking to the general theme, is comorbidities how you plan your patient treatment differently?
Absolutely, absolutely.
Dr. Rahul sir, would your choice of reconstruction be affected by comorbidities of a patient?
I mean, I would like to say no, but if that is not a plain and simple no, but in certain situations, yes, with the modern, you know, anesthesia and all that, we can go ahead with the same plan. But there are situations like chronic alcoholics and all that, and we would want to keep the plan as simple as possible in those patients.
Okay. Dr. Mitali, would you have a simpler reconstruction in a patient who has more comorbidities or is at advanced age, despite him warranting probably a more specialized microvascular reconstruction?
Excellent point, Abhishek. And in fact, I'm really impressed by the points that you're bringing forth. Very, very pertinent. The answer is very obvious here. What you want is, you know, the patient should be well, the patient should come out well, and you must optimize your choice of treatment based upon the patient's general condition. The performance status of the patient is one of the most important prerequisites before you decide upon definitive treatment. So yes, our choice of reconstruction to a large extent would vary depending upon the performance status of the patient.
Okay, so I'm going to carry this theme in the next scenario. This is a 30-year-old male tobacco chewer, excellent mouth opening, growth over the hard palate and over the upper alveolus. Biopsy is squamous cell carcinoma. May I ask the radiation oncologist first, Dr. Dinesh Singh and Dr. Jyotika Jain, ma'am, what would be your treatment of choice for this patient?
This patient, how big is the growth, and are there any involvement of the lymph nodes with this patient?
Okay, so let's say that the growth is bone erosive. It is eroding into the palate with no intrasinus extension, and there are no neck nodes. So he's a T4A N0 carcinoma of the hard palate.
Well, in this patient, surgery plays the pivotal role. And if upfront surgery with good reconstruction can be planned, followed by post-operative radiation will be a good choice. And if the operating surgeon feels that this may be not feasible, then we can go for pre-operative radiation with concurrent chemotherapy and maybe 45 to 50 gray, and then the patient can be taken up for surgical reconstruction and surgical resection and reconstruction of this patient.
Okay, let me put that question in a slightly tweaked manner to Dr. Jyotika Jain. If this were, let's say, a T3 N0 carcinoma of the hard palate, there is no bone erosion. It's just an expansile soft tissue lesion. Given that surgery would then entail resection of the palate, would you prefer radiation or definitive chemoradiation for this patient?
No. Even for hard palate patients, definitely we'll go ahead with surgery first. Surgery followed by radiation. Had it been oropharyngeal carcinoma, soft palate lesion, definitely we would have gone for CTRT.
So if this were a lesion not on the hard palate but the soft palate, which of the surgeons here, Dr. Rahul, Dr. Kapila, Dr. Ashutosh, Dr. Mitali, Dr. Deepak, which of you surgeons would have still wanted to undergo for this patient to undergo surgery? Let's say this is the same lesion, not on the hard but on the soft palate.
Hi, Dr. Ashutosh this side. So my first option would be to send the patient for from causes and try going for an option of the chemoradiation in this patient, because even though we have the microvascular reconstructions and all forms of reconstructions in our hand, the amount of morbidity associated will be little less, because it's going to affect the velopharyngeal function. The swelling is going to affect it a lot if we go for an upfront surgery. So my option would tilt slightly towards the radiation in consultation with the radiation oncologist.
So, Dr. Ashutosh, you are referring to a patient with a soft palate lesion. Is that correct?
Yes.
And for this hard palate, would surgery be your primary choice?
Yes, that would be my primary choice, because it's got bone destruction. Radiation itself might not be the final treatment or the complete treatment for such a patient. So surgery in such a case would be my first option to go in this patient.
Okay, Dr. Kapila, Dr. Mitali, would you agree with that? Is Dr. Deepak here? I don't think he's here.
I agree with this.
All right. So it is very important to select your treatment modality for subsites within the oral cancer. Quickly, to all the clinical oncologists here, to the surgeons, to the radiation oncologist, which of your subsites within the oral cavity, not going to the oropharynx, would you primarily treat with radiation? If you could just elaborate that.
So I'll say in the oral cavity, the basic treatment, first you go for surgery. Basically, either it is a hard palate or lateral border of tongue or buccal mucosa or floor of mouth. You always prefer surgery followed by radiation, not radiation, unless there is some contraindication for surgery or very small buccal mucosa lesion is there, or tongue, very suitable case for in which you can give implant. Brachytherapy can be added only in those patients, or you can say lip angle commissural tumor where surgeon is not very comfortable. At that places, when we are adding brachytherapy, then only we can say you take radiation, but definitely you prefer surgery at all these sites in the oral cavity.
Right. Dr. Shiva Manjunath sir, may I just ask you, how would you approach this patient surgically?
Dr. Abhishek, although I am not an oncosurgeon, we would be having a consultation with the radiation, and also the surgical aspect will consider it. Depending on the lesion, depending on the conditions, we'll take a call on this.
All right. So can I quickly ask that question to Dr. Rahul Thakur, sir?
Yeah, so in this case, as it is going posteriorly, I would debate Weber perfusion with a Dieffenbach to a lower lip split. And because my reconstruction is going to be microvascular in this case, I would prefer to do exclusively with a lower lip split and avoid an upper, incision.
Okay, you've taken away my next question. My next question was going to be that how are you going to reconstruct this across the surgeons? If you could, just enumerate your preferred mode of reconstruction for this kind of lesion. So, Dr. Rahul, Dr. Kapila, Dr. Mitali, if you could just, Dr. Ashutosh, if you could, tell me what would be your preferred method of reconstruction, rehabilitation for such a defect. This is going to be a left infrastructure maxillectomy. The defect is going to reach up to the midline and up to the canine anteriorly.
So my first line of reconstruction would be a radial artery forearm flap. If it is or an anterolateral thigh flap, the difficulty with the anterolateral thigh would be the reach of the pedicle. So first option would be radial artery flap for this.
Dr. Ashutosh?
Yeah, I would agree to that. The only thing would be I would look at the extension. If there's any extension to the ITF. So in case I have to go for a low ITF clearance, maybe I have to incorporate a coronoidectomy also along with the infrastructure maxillectomy to give a good ITF clearance. And in that case, the defect is a little more. I might choose up an ALT flap, but looking at the consideration, maybe the pedicle may be a problematic situation. So in between a radial artery or a flap, depending upon the physical appearance of the patient.
Okay.
I don't think so. No, I would prefer a fibula for this. He's a 38-year-old. He's quite dentate. A fibula would be a good option. And you could also consider implants on the fibula also at a later date and give him a good dentition later.
None of you going for an obturator at all in this patient?
He's 38. He's dentate. Obviously, give him a free flap.
So right, that brings me back to my last point. So would the presence of comorbidities or advanced age, kind of affect your treatment decision to offer him an obturator instead of a free flap?
Definitely, if he was of an advanced stage, if his comorbidities would put him away from giving him an option of a free flap, definitely we would have considered a obturator. Definitely.
Mitali, for this kind of Brown's maxillary defect, obturators work just as fine as free flaps. Why are all of the surgeons wearing on the side of the free flap?
Well, again, because probably he's 38, he deserves to get the best outcomes. And the fact that the disease, although it looks like it's restricted to the left-sided palate, it extends also to the soft palate, and I believe you would cross over to the opposite side and take out both the canines. So I'm not too sure the prosthodontist would be comfortable putting in an obturator. But having said that, if it's possible, yes, that is an option as well, Dr. Abhishek.
Okay, so this patient eventually underwent surgery with an obturator because he was unfolding for a free flap. He wanted to avail a government scheme. We tried to apply for the government scheme, and the scheme would not allow us to do a free flap. An obturator is what he got. May I ask any of the specialists here to comment upon the utility of an obturator in such a defect?
My concern about the obturator, in this case, we don't have oral submucous fibrosis, but the majority have oral submucous fibrosis. So when you do a maxillectomy and post-radiation, the obturator really is not an option. In this particular case, definitely. And we have also done cases where we have done a radial artery forearm flap and given obturator on it because it's a low profile flap with teeth. So yes, if there is no submucous fibrosis, obturator is an option, can be considered. Even if the soft palate is involved, an obturator can be given.
Dr. Shiva sir, at what point in this patient's management would you want to come into the picture?
Shiri's got dropped off because of the network problem. He's just joining back.
Okay. Okay, so I think we've covered that point pretty well. For most of our hard palate defects, the obturator does exist as an option. And if you look at studies comparing obturator versus free flaps for these kind of defects, and especially for the lower Brown classification defects, obturator would work just as fine. In today's day and age, microescalar would probably receive the thumbs up in the hands of most surgeons, except when there are constraints with age or affordability or availability. Any experience with zygomatic implants? May I ask? And we are really, if you can see, we are kind of shifting gears towards dental rehab here because that was what was the brief given to me. So we are kind of shifting gears to that direction. Any experience with zygomatic implants?
So I have done quite a few of them. And this is a polished implant which is seen. So that, and what is known as a zip flap, zygomatic implant pregnated flap. So you can do a free flap along with the zygomatic implant. So we have done quite a few of zygomatic implants, and especially for mucormycosis also. So yes.
Dr. Raul, so you're always taking my next point on my next slide. So anyways, so could you elaborate on that? When would you use, that was an excellent point. When would you use both an implant and a free flap?
So with the free flap, you have to generally use a radial artery flap because that's a low profile flap, and we need to have a bigger skin pedicle. So we need to impregnate the zygomatic implants, and you can use it with the flap, or you can have a removable prosthesis too. So a flap is not a must. And zygomatic implants, I have been using it since last 4 or 5 years. There are 2 systems available. One is a polished one, which is Norris Medical. Other is an unpolished collar, which is Nobel. I have both the systems in-house, and it's a fantastic reconstructive option for the maxilla. For one point Dr. Kapila made with the fibula, I would be, in our hands, we do fibula for anterior defects where the septum and all that is lost, where the nose requires support. For lateral, I really feel the dental rehab is more of a dream than a reality. So we don't do any fibulas for lateral defects of the maxilla. That's my experience. If other surgeons have other experiences, I would like to hear from them.
Any of you would have, Dr. Ashutosh, would you want to comment on whether you've had experience using zygomatic implants?
Yeah, if we follow kind of the same principles, when there is an anterior defect, the premaxillar portion that is involved, then the only option choice that we go for is otherwise a lateral defect, as sir pointed out. I mean, we are following the same shoes, whatever he is practicing. And that's when we go for a free flap combined with zygomatic implants for such patients.
Okay, wonderful. So as Dr. Rahul sir was mentioning, within a big problem sometimes lies big opportunities, and we know how surgery developed after World Wars I and II, and with the current pandemic having affected us so badly, especially with the COVID-associated mucormycosis, it was a huge challenge to treat these patients and also to rehabilitate these patients. But we've also gained valuable wisdom from rehabilitation of these patients. These are some pictures courtesy of Dr. Dehane from Kingsway Hospital, Nagpur. So what have we learned from the pandemic associated mucormycosis? How can we rehabilitate our patients better, having gained that wisdom? Dr. Shiva sir, if you would want to take that, or any of the surgeons here. So let me rephrase that question. Would any of your surgeons now be okay with a secondary rehabilitation? Is that an option at all?
Secondary rehab for the maxilla?
For the maxilla.
Well, secondary rehab post radiation, I would generally not venture into. If it is not post radiation, if it's otherwise, yes, I've done some temporalis flaps. If the patient, is really not happy with the obturator, I have done. But post radiation, I've really, kind of tried to avoid situations like that.
Okay. Dr. Shruti, how much time do I have?
So another 10 minutes, 10 more minutes.
Sure. So another 5 to 10 minutes, let me take another case, 22-year-old young male, lesion in the left body and the ramus of the mandible. That is a lesion, as you can see, multilocular radiolucent bony expansile lesion. There is paresthesia of the left lower lip. Biopsy was done, and which was ameloblastoma. What would be the plan for this patient? If I could have all the surgeons one by one. If I could also have Dr. Shiva sir, let's ask him the same question. At what point in this patient's treatment would you want to step in?
So Shiva sir has not been able to join us back. He's having a lot of technical problems.
Okay, Dr. Kapila, Dr. Mitali, Dr. Rahul sir, Dr. Ashutosh, multilocular radiolucent lesion here, multilocular ameloblastoma. What is going to be your plan for this patient? Young male. Let's say this is an ameloblastic carcinoma. Let's stick to the theme of oral cancers.
So if it is ameloblastoma, also my plan would be a surgical resection. It would be very difficult to save the condyle for this. If I cannot save the condyle, I would be doing a straightforward free fibula reconstruction with a ramal reconstruction, not really keen on dental implant reconstruction because of the swing, which would happen if I can't save the condyle. If I can save the condyle, we have done, double barrel fibulas, and we have then dentally rehabilitated. But otherwise, with a single barrel fibula to dentally rehabilitate, it becomes very difficult, and there is a lot of tissue growth.
All right. So that brings me to one of the favorite questions of debates: primary or secondary implants? Let's say this were an ameloblastoma. Let's say this were an oral cancer or ameloblastic carcinoma. Primary or secondary implants?
I don't have any experience with primary implants, so my experience is with secondary.
Even for benign lesions, would you prefer secondary implants?
In my practice so far, I have been practicing secondary implants.
Kapila, you wanted to say something?
For an ameloblastoma, we would do a primary implant.
So do you have good experience with primary implants?
I won't say good experience. We just go ameloblastoma as such. We don't see too much of it. We probably say 2 or 3 a year maybe. But most or if it's ameloblastoma, they all get primary implants.
Okay, any experience with reverse planning, virtual 3D planning? When would you utilize this wonderful technology coming? So when would you utilize this? Kapila, allow me this. This is a panel based on that.
Okay, sure, go ahead. Sorry.
So we do commonly practice this virtual 3D planning in our practice. There are some very good companies that have come up in India, and especially for these cases of the benign case, we earlier were going for a secondary plan. We would resect it, we would get our fibulas made, then wait for some time, and then give the implants. Recently, only we have started venturing into doing this entire planning, deciding upon the location of the implants within the fibula and giving the implants, so that when the patient comes out of the OT setting, he has his dentate condition which was there pre-operatively existing within the patient.
Okay. Any experience with synthetic implants? Let's say for a benign condition, let's say something like a peak implant.
No, still very scared to incorporate that into my practice. But I think if someone has a greater experience, would be able to comment much better on that.
Correct. So extrusion is a big fear which all of us surgeons have. Whether this fear is correctly based or whether it's unbased, only time will tell. But as of now, certainly a no-no for malignancies. Certainly a no-no for malignancies. Synthetic implants will not work with malignancies, especially those who are going to require adjuvant radiation.
May I add one thing, Abhishek?
Yes, please, sir, please.
Malignancy, absolute no-no, and also a no-no for the mandible, because these companies are pushing it for the mandible mid-third and all that. Absolute no-no for that also.
Okay, even for benign conditions, would you avoid using an implant?
Yeah.
Okay.
These companies are pushing for middle third. They are pushing.
It will fail. Certainly, malignancy is a big no. We all know that with radiation, the behavior of these implants is, unless we have good longitudinal studies on them, we should not venture into this. For benign conditions, we really should wait for emerging data whether extrusion is really a problem. Dr. Mitali, at your center, if you were to do fibula for oral cancer, how many of these patients would eventually want a dental rehabilitation? Do a large proportion of patients ask for dental rehabilitation?
Oh yes, they do, but like as all the other panelists have emphasized, primary implant per se is not an option I give to my patients at all. But yes, secondary implants, particularly those who are disease-free at least for 2 years post-radiation therapy, secondary implants is an option I give.
Is post-treatment trismus a big impediment in offering you offering them the dental implants? Is that a big problem? Because in my setting, a lot of patients who would have been good for dental implants, when they come 1.5 years after their radiation, they are really not good candidates because of trismus. So is that something that we share across the country?
I mean, post fibula, post RT, trismus per se is not so common. But yes, of course, if the patient has coexisting OSMF and if there is anything more than grade 2 trismus, obviously putting in an implant or in fact any dental care per se would be an impediment.
Okay, so take home messages from all of you. For surgeons who are offering free fibula to their patients with lateral or central mandibular defects, should eventual dental rehabilitation be one of the primary goals to begin with?
Yes.
Absolutely, yes.
Yes, definitely.
Sure. So I think I'll move on. What is the role of prosthodontist? And I've really enumerated here, but what is really the role of prosthodontist while you're treating oral cancers? I've been helped by Dr. B. Srinivasan, who's really lended me some of his slides. But if you could just enumerate me in your practice, where would you want your prosthodontist to come in and help you with rehab?
So as you right, I think you had a slide for that. The bite guide we tend to give, basically we do post, if you are doing a pectoralis flap, we give interdental wiring and elastics, and then after radiation, before radiation, we remove them, and then the prosthodontist gives a bite guide. For obturators is definitely for maxillary defects. So these are the two main indications. We have not utilized for tongue prosthesis any prosthetic help, but these are the two main areas where the prosthodontist comes and helps.
Yeah, I think one of the emerging and untapped areas is upper facial defects, and this is really which came into core post the pandemic. And we, upper facial defects cannot be really reconstructed to their optimal figure before surgery. So upper facial defects is one of the areas where I would really bring in prosthodontic help. Any comments from any of the panelists?
I guess, Abhishek, the slide that you are showing us is very self-explanatory.
Yeah.
It by and large covers all the gamut of prosthodontics for head neck surgery.
Right. And once again, I acknowledge the help of B. Srinivasan for this slide. Defect-specific reconstruction / prosthesis. So we know that for soft palate and for posterior tongue, also for the eye, we just kind of summarize these. These would certainly be areas where prosthesis would help. We went about hard palate and we saw that how obturator may be an effective, cost-effective, function-effective solution for those who are unwilling, unfolding for free flaps. We also saw how dental rehabilitation, at least in the posterior segment of maxilla, may not be a dream worth chasing. I also spoke about how prosthetics have a big role to play in upper facial defects. Before I end, and maybe a couple of questions to the medical and the radiation oncologist. So this is a 45-year-old male, a pretty common patient to come to any of our OPDs. Long-standing, non-specific oral and dental issues. Ulcer of the left buccal, left lower gingiva buccal sulcus, which was biopsied twice elsewhere, did not turn out to be anything. Eventually, a deeper biopsy revealed squamous cell carcinoma. So what are typically the problems with such patients? Poor dental hygiene, trismus, multiple aphthae. You can see there is a glossitis patch on the tongue as well. So if we have to kind of comprehensively treat these patients, what are some of the issues you might face?
Well, as rightly put by you, the problems are poor oral hygiene, trismus, and poor nutrition with these patients. And these patients, they need multidisciplinary care, like they need the surgical treatment and the post-operative radiation and chemotherapy. So that makes things even more complicated. So we need to first, we embark on any treatment, we go for the dental counseling and dental prophylaxis of these patients, so that they undergo the fluoride treatment and whatever preventive maintenance needs to be done. Then only we go for the definitive treatment, which comprises of surgical resection and post-operative treatment.
Absolutely.
And, and the help of a good nutritionist and a psychologist is very much required, because these patients, they undergo a lot of mucositis, pain, and poor nutrition, and they refuse to they are not very cooperative patients to manage with. So all the need of help is required.
So that was the point that I wanted to bring forth. As surgeons, and I'm guilty of that, we only look at a part of the picture. There is a whole lot to the picture. We are only treating the evident, more sinister disease, but there are a lot of issues which need to be tackled with. Once again, as I'm repeating myself, my brief for this panel, as given by Dr. Gupta sir, was to emphasize the need for dental component into the treatment coming into very early. And as Dr. Dinesh Singh sir very aptly mentioned, there are a lot of post-radiation sequelae which can be tackled very well, or at least prevented to an extent if dental rehab is brought in early. And this is borne very well in literature. There is ample evidence to say that whenever there is a good pre-operative oral health, it decreases post-op problems associated with inflammation and also complications with ORN and even trismus. In fact, this has also been included in NCCN, and NCCN clearly mentions that there are specific goals of pre-RT or dental or oral evaluation. Now, may I ask Dr. Dinesh Singh sir and Dr. Jain ma'am, so how much before your dental treatment would you want your patient to undergo, before your radiation treatment, would you want your patient to undergo dental rehab? Also, I think this point was covered somewhere during one of the earlier slides. What do you want us oncosurgeons to finish on the table? How much would you want, especially with relation to the dental things, what would you want us to finish on the table so that the gap between dental treatment and post-op radiation is minimized?
So this is a very important point. I'll say, Dr. Abhishek, a lot of patients, they undergo surgery and after that they report us with the carious teeth. So I think our surgeon colleagues, when they see the patient and they are planning surgery, at that very moment, all these things should be evaluated if patient is undergoing surgery so that we don't lapse. Patient is already so apprehensive. By the time post-operative recovery is there, 3 to 4 weeks post-operatively, patient report us and then you tell them, okay, 3 carious teeth, they are there, then it becomes difficult. So it will be really good if this part, if any patient is going to our surgeon colleagues, that should be tackled over there so that by the time they reach us, no further delay in the treatment happens. So that is really important.
Dr. Dinesh Singh sir, xerostomia is really a problem which compounds this. It has a negative cyclical effect. So how do you manage your patients with xerostomia during and post-treatment?
A good hydration is very critical on the part of the patient and keeping a very good hygiene. So I instruct them to have a frequent water intake so that they keep their mouth and throat wet during the treatment, and also a good cleanliness is maintained by them. A good nutrition is very important so that the mucosa is not breaking down during the treatment. And then also when we talk about the radiation field, then we try to keep dose to the parotids and the submandibular to the as low as we can achieve. But then that again will depend upon the location of our target volumes, where they are, and how much we are able to achieve that. So a combination of all these factors is important, and counseling with a psychologist and a nutritionist is important in these cases.
Okay. Do we have Dr. Shiva sir back? Is he there?
No, sir, he is not able to join.
Okay, Dr. Ashutosh and Dr. Rahul sir, when would you do prophylactic extractions at surgery? Apart from generally carious teeth, obviously carious teeth, when would you do extractions at surgery?
So the best time for extraction is definitely on table, and sometimes the contralateral teeth, if it's going to be a soft tissue reconstruction, we know. So it's best to address the contralateral teeth. Like if you're doing a mandibulectomy or posterior mandibulectomy, it's wise to remove the maxillary posterior teeth also, because they'll be having no functional use.
Correct. I also find a very common thing in my practice is the flap bite of the anterior most tooth, which is closest to the flap. So if that is not tackled during surgery, and if it is creating a problem to radiation, one of the things which we do in my practice, because you cannot extract them, is do a crown amputation. So that works just as well.
One thing I'd like to add is most of our patients that come to us, so pre-operatively we make sure that they see a dental oncologist and go for scaling, because the scaling is a very important source of infection after the resections. And of course, the point that you pointed out, the teeth next to the flap, of course, that needs to be taken out.
But I think what you mentioned, Dr. Abhishek, very valid. So anterior teeth to the flap. So I think especially if there is SMF, what we do is, if you are planning a resection from the premolar, we will extract one tooth anterior to the
one tooth anterior. So on table, whatever tooth you think needs to be extracted, go one tooth anterior to it. One of the practical problems I found is if there is still a tooth bite and the patient is undergoing radiation or is immediate post-op, post-RT, you can still do a crown amputation for that patient very safely without increasing your risk of osteoradenoprosis.
Perfect.
Okay, so before shifting gears, this is really the last case for me. This is, let's say, a male in his early 60s, difficulty in swallowing. He has a large tongue mass extending to the right half of the tongue. Extrinsic muscles are involved, posteriorly involving the base of tongue and tonsil. Which of you surgeons would want to venture surgery into this? Is Dr. Vikas Goswami there?
No, sir, not there.
He's not there. Okay, so let's say that on
Yes.
fiber optic scopic examination, the lesion was just onto the base of tongue. So now I've tweaked that scenario a bit. Vallicula, however, is free. Let's say this is the kind of lesion you have. Which of you surgeons would want to do an upfront surgery for this? Kapila, Mitali, Ashutosh. And then what would you want to do? Dr. Dinesh Singh sir, Dr. Jain ma'am, would you want to tackle this patient with upfront chemo radiation?
My treatment of choice first would be to give a neoadjuvant chemotherapy first to this patient and see the response, how the response come out. If I see that the response is very good post neoadjuvant chemotherapy, then I would go for an option of CTRT. And if I see that the response has not been good, then probably weigh my looking at the condition of the patient, that is post neoadjuvant chemotherapy, weigh my options of surgery versus CTRT. Maybe surgery may take over the option of chemoradiation, but that would first NCT would be the choice of treatment.
So in my opinion, we'll definitely go for CTRT, followed by if any residual is there, patient will go for surgery if any residual is there. So if we see all literature, McKenzie, meta-analysis, all of them, they suggested CTRT is definitely superior. Patient is young and can tolerate CTRT. I'll prefer CTRT, followed by if any residual, patient goes for surgery.
So we often see this dichotomy in opinion. Surgeons would want NACT, radiation oncologists would want CTRT. I wish we had a medical oncologist on panel, but there isn't one. Mitali, is it going to be total glossectomy for this patient for you?
So, Abhishek, you have used the right terminologies to describe that, yes, one can resect, you can resect anything being a surgeon, but should one resect, as in, would it be functionally compatible? Involvement of the epiglottis, involvement of the vallicula per se is a sign of unresectability in my book, or for that matter, any head neck surgeon's book, and the patient would go on a non-surgical modality of treatment. So there are various other factors depending upon how bad the soft tissue is on evaluation under anesthesia, how good the general condition of the patient is. I would decide between a neoadjuvant treatment or chemoradiation.
Okay, so one final point, we know what is unresectable. We know what is unresectable. We know what is technically unresectable when the R0 is not assured. I just want all of you to frame a quick guideline for functional unresectability. Would total glossectomy be functional unresectability for you? For most of us, it is not. But let's say total glossectomy with segmental mandibulectomy or hemimandibulectomy, would that be functional unresectability for you?
If you're going to do a total gloss with a segmental mandibulectomy, I would rather throw in a laryngectomy also. He'll probably be more functional after
Just
that.
for fun?
Not just for fun. He will be functionally, he'll be better off. Yeah. Because obviously his main issue is going to be aspiration. You remove the larynx, then he's able to, at least he'll be able to eat. It'll just be a tube, but he'll be able to eat. And obviously it will not be good. It will be a quality of life is going to be very poor, but definitely I think doing a laryngectomy along with it is going to be better. Otherwise, it doesn't make sense to do.
I think in those cases we should.
That's
functionally incompatible.
Correct. So, Dr. Jain ma'am, Dr. Singh sir, which would be your clear-cut indications for NACT in oral cancer? So and probably that would be my last question to you.
So yeah, well, I would like to say that if the surgeon is of the opinion that he will be able to sometime get hold of patients surgically, only then we should go for NACT. Otherwise, if he thinks that he will never be able to definitely take up for surgery, then we should not go for NACT. We should go for radiation with concurrent chemotherapy.
So
yes, go on.
What we are following is if disease is too bulky, not really encompassable in our field, or lymph nodes, they are too big, and where I am expecting micrometastasis at the time of presentation, which are not being picked. In those cases, we prefer neoadjuvant chemotherapy. Otherwise, if it is encompassable and I can take care with radiation, disease is not too bulky in the sense large 5-6 centimeters lymph nodes, they are there, I'll prefer CTRT.
Okay, and also probably bioselection, if bulky nodes, extensive disease, maybe you want to give NACT, see how any of your patient is response well, then take him up for definitive chemoradiation. Anyway, that brings us to the end of this panel. It has been absolutely wonderful interacting with all of you, getting your opinions. Wonderful program once again, Dr. Gupta sir. And let me say this, that oral cancer treatment in today's era is not a tug of war between different specialties of surgeons themselves, or between the surgeons and other clinical oncologists, radiation medical oncologists. It is really an exercise in cooperation between specialties and patient selection. So thank you very much once again. Let me thank all the panelists. Let me thank the organizers for having me here. And may I take the baton back to the chairpersons for their remarks. Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you, everyone.
So I'll quickly invite Dr. Somesh Chandra, who is currently the director of Head Surgical Oncology at Sterling Hospitals and Sterling Specialty Clinic Cancer Center. He is the section editor for Head and Neck IGSO and past associate professor of GCRI, executive member of IASO and director of KCHRS Goraj Boroda. So has been extensively working in this field and has been also the crusader of oral cancer in this field. I'll invite sir to quickly give the concluding remarks for the day and also the panel discussion.
Thank you, Shruti. I think we are all very thankful to all the speakers earlier and to all the panelists and Dr. Abhishek for conducting a brilliant panel discussion. The issue of multidisciplinary care has been amply demonstrated today. I mean, we have divided medicine into different disciplines. But what we have been practicing is multidivisionary medicine, not multidisciplinary medicine. And that was the prime objective of today's session and this entire 4-session theme in April this year, that how do we manage to come together? Unless we start talking together, we have different societies and we talk in different societies about getting together, but we never talk together. So I think this is a very good platform, ICanCaRe edition, the second edition, where we are able to highlight the importance of all the disciplines involved in the management of oral and head and neck cancers, and the oft neglected specialties of dental sciences, max facts, nutrition, physiotherapy, and how have been brought together, and we now know how important it is. Today's session started with trismus. Trismus is a symptom of oral cancer. It's a symptom of oral pre-malignant diseases. It is a sequelae of treatment for oral cancer, and it is also a cause for oral cancer. We have shown that with the Bayesian analysis. And we had a nice long session on trismus on osteoradionecrosis, because that's where that's an iatrogenic disease which we are causing. We must know how to prevent that and how to treat that, and how many people are involved in that. And after that, we had a very nice session on panel discussion highlighting the often neglected nuances of oral cancer patients. And we are all very thankful to all the panelists and the moderators and all the speakers. And I'm sure there's a lot of takeaway from today's session. Thank you.
Thank you so much, sir. I think we had a prolific day too, because we had a great technical session and a great panel discussion, which give a lot of insights about what we learn about the management with multiple teams altogether. And as Dr. Abhishek has rightly summarized in the panel discussion and also given hints by Dr. Somesh sir, that it is a multimodal approach, which is done together with everyone. With this, now we come to the most exciting event for the day, the quiz. And before we move on to the quiz, let me talk about the prizes which are going to be there. So certificates would be given to the participants from the organizing committee, to all the winners as well as those who participate in the program. Scholarship for the Certified Tobacco Cessation Specialist program would also be given to the participants. It is accredited program by Gujarat University. The first, second and third participants would get scholarship of 50%, 40%, 30% respectively. The next set of 16 individuals are going to win 20% scholarship for this program. There is a special gift hamper from Aji Foods for all the top 3 winners. And of course, gift coupon will be given by ICanCaRe to all the 20 winners who win this quiz program. Now, let me quickly talk about the CTCS program. This is an advanced level certification which talks about the clinical intervention for tobacco cessation, has been researched extensively by ICanCaRe in collaboration with numerous experts across the country in Gujarat University, has been medically validated, has a data-driven protocol, and is based on the principles of evidence-based cessation. The quiz leaders for the evening are Dr. Dushyant Mandlik, sir is treasurer of Foundation of Head and Neck Oncology, and Dr. Rashmi Shukla. Madam is the senior consultant of radiation oncology at Max Healthcare. So I'll invite Dushyant sir to please give the instructions to the participants.
Good evening, Shruti, and welcome you all to this second day of quiz. It was an exciting day today with a lot of learning from masters of this field, and now we will have the quiz on the same. I will, in a brief, go for what is the selection process for the quiz. This is the online quiz. Today is the second day of this International Oral Cancer E-Conclave. And to win, you have to participate in all the 3 quizzes in all the 3 days. The quiz would have 20 questions on the theme of the day. The points obtained for all the 3 days would be added to select the winner. In case there is a tie, the fastest time submitted will be considered. Winners would be the highest and the fastest total of the 3 quiz, and results would be declared on the forum. All winners will get certificates, scholarships for CTCS, and top 3 will get gift hampers. And the winners can avail the scholarships in the next scheduled online CTCS course, which is an excellent course. As always, the decision by the organizers will be final and abiding, and all participants for the quiz will get discount coupons. And above that, the participants will have enriching experience by answering the questions also. So that also goes without saying. So Shruti, back to you to introduce our today's quiz master, who have been constantly enriching us throughout the sessions. Dr. Mithali, yeah.
I thank you so much, sir. So I take this pleasure to invite Dr. Mithali Dandekar. Madam is consultant of head and neck surgical oncology at Paras Cancer Center and Mahavir Cancer Sansthan in Patna. So I'll hand it over to ma'am to please give the instructions for the evening.
Thanks, Shruti, and thank you, Dr. Dushyant, for the kind introduction. So I think the link has been shared with all the participants, and Dr. Pavan Gupta has been instrumental in putting it together. Am I supposed to speak out the instructions? Yeah. So a link will be shared in the chat box, and participants need to click on the given link. You have to fill in your details, your email, your name, your center, the institution, and you have to start answering the questions. The questions are simple, non-controversial. There are 20 questions, and you'll be given a total of 10 minutes to answer them. It is in the form of an MCQ. You have to tick the right answer and submit your responses once you're done. And needless to say, the decision of the leader and the quiz master shall be final in the decision making. So all will be muted, and the chat box will be disabled to enhance or ensure that there's impartiality. So this is a link to the quiz.
So shared in the chat box. Please go to the chat box and click on the link. And this is the link again we have shared in the chat box. Please, you can immediately go to the link and you can start answering. So everyone, are you ready?
Yeah, Mithali ma'am, over to you again.
Yeah, it's just she's just while she's waiting, while she's joining back. So every one of you just go to the quiz link. So it is there, and then write your email, mobile, name, institute, city, and occupation. Please make sure that you are writing the same the same mobile and email and the name as you did in the quiz day 1, because otherwise it will be very difficult to correlate that you are the right person. Then you are likely to be not being part of the quiz winner of the quiz. So I think now we are ready for the, if everyone is ready, then let's go for the quiz. Over to Dr. Mitali for the quiz questions. Everyone is ready? Just put, someone can put hi in the chat box. Yeah, Dr. Mitali is ready now. Yeah,
Yes,
over to you,
sir.
Dr. Mitali, for the question number 1.
So question number 1, structures preserved in modified radical neck dissection except sternomastoid muscle, facial artery, internal jugular vein, spinal accessory nerve, all of the above are preserved. Question number 2, name of the maneuver to prevent marginal mandibular nerve injury. Hayes-Martin maneuver, Allen's maneuver, Valsalva's maneuver, Cocker's maneuver. Question number 3, which CT-based landmark differentiates level 2 from level 3 stations of lymph
There
nodes in
is
the neck?
something, quiz link is not open, Shruti, quiz link is not open. Something is there, something wrong? Just check.
Sir, it is opening.
Yeah, it's opening, sir. I'll just stop share just to see what is the problem.
It is opening. There is no problem. I can see it is opening. Yeah, yeah, please go ahead. I think it is opening. And just give 2 seconds before the next question, Shruti.
Shall I continue with question 3?
It is saying that quiz link is for day 1. Just check. Take note. Just what is wrong? It is day 2 only.
A lot of people seem to be having a problem with the link.
No, it is day 2. It's absolutely fine, I think. It is absolutely fine. It is day 2 only. I just checked. So it is day 2 only.
It is day 2 quiz only. I also checked.
Yeah, it is day 2.
I think, Shruti, we can go ahead. Dr. Pawan?
Yeah, I think we will go ahead. Just in for those who are, I'm just sharing the direct, this is
I
our.
shared the direct link to the Google form already. So in case the participants were facing problem with the link, so please use the direct link to join the quiz for day 2. It's there on the chat box.
So let's continue.
Yeah, I think.
Yeah, okay. So question 3, which CT-based landmark differentiates level 2 from level 3 stations of lymph nodes in the neck? The hyoid bone, thyroid cartilage, cricoid cartilage, or the posterior belly of digastric? Next question, please. After surgery and or radiation, that could potentially aggravate trismus, the following prophylactic or therapeutic options could be considered: tongue depressors, massage, botulinum toxin type A injections, or commercial devices and physiotherapy. Question number 5. TrisCare, the innovative mouth opening device for Christmas care, is made of stainless steel, acrylic material, titanium, polyoxymethylene, or none of the above. Question 6. After previous parotidectomy, if a patient complains of flushing and sweating in the area of surgery while eating, the most likely diagnosis is Frey syndrome, Horner syndrome, Behcet syndrome, or Bloom syndrome. Question number 7. A dentist refers a patient with a fluctuant swelling of the anterior midline of the hard palate. The most probable diagnosis is a nasopalatine duct cyst, a ranula or a mucocele, irritation fibroma, or congenital epulis. Question number 8. If a radiology report on the panoramic X-ray film of a patient reads sunburst appearance of the anterior mandible, what is the most probable diagnosis? Osteosarcoma, Paget's disease, fibrous dysplasia, or none of the above? The next question, question number 9. After radiation therapy, patients are advised to, shall I wait or shall we proceed further? There's something in the chat box here.
Please proceed. I think most of the people are able to open. I think only.
Okay. So I repeat, sure. So I repeat question number 9. After radiation therapy, patients are advised to have frequent dental examinations and use of water for relief of xerostomia, decrease sucrose intake and use fluoride supplement, decrease sucrose intake and use water for relief of xerostomia. And option D, have frequent dental examinations, prophylactic treatment, use of fluoride supplement, decrease sucrose intake, and use water for relief of xerostomia. Question number 10. Titanium implants placed before radiation therapy should be option A, left alone because they pose no contraindication to radiation therapy. Option B, removed because they pose a threat to the surrounding bone. Option C, removed because they increase the risk of infection in the bone. And option D, removed because they are a source of osteoradionecrosis. So we are halfway through. Now question number 11. The surgical obturator after maxillectomy is intended to option A, prevent infection, prevent recurrence, and stabilize surgical packing. Option B, allow for nutrition by mouth and stabilize surgical packing. Option C, allow for nutrition by mouth, provide intelligible speech, and stabilize surgical packing. Option number D is all of the above. Question number 12. A non-reconstructed maxillectomy defect causes option A, nasal regurgitation. Option B, nasal regurgitation and difficulty in chewing. Option C, nasal regurgitation and hypernasal speech. And option D, nasal regurgitation, hypernasal speech, and difficulty in chewing. Question number 13. Which statement is correct in palatal reconstruction? Option A, incisors are the preferred anchors for obturators. Option B, canine teeth are the preferred anchors for obturators. Option C, molars are the preferred anchors for obturators. And option D, none of the above. Question number 14. Adjuvant radiation therapy is indicated for option A, advanced stage disease. Option B, closed surgical margins. Option C, multiple nodal metastasis. And option D, all of the above. Question number 15.
Which of the following is the correct sequence for increasing the risk of malignancy in a salivary neoplasm? Parotid is lesser than submandibular is lesser than minor salivary gland. Minor salivary gland is lesser than submandibular gland is lesser than parotid. Submandibular gland is lesser than parotid is lesser than minor salivary gland. And option D, parotid is less than minor salivary gland is less than submandibular gland. 5 more questions. So question 16, a 35-year-old man with a history of betel nut chewing presents with recent onset trismus and pain. An exophytic tumor of the buccal mucosa measuring 5 into 3 centimeters. Biopsy shows squamous cell carcinoma. Radiographic assessment shows mandibular erosion. The clinical T stage of this patient is most likely to be T1, T2, T3, or last option, T4A. Question number 17. The patient in the figure has squamous cell carcinoma of the left buccal mucosa and retromolar trigone. Assessment of the mandible is most suitably done by a computed tomography, an OPG, option C, positron emission tomography or PET scan, and the option D is an MRI scan. Question number 18. Which of the following about tobacco and oral cancer are true? Option A, there is a dose-response relationship. Option B, there is synergistic interaction with alcohol. Option C, it is associated with mutations in P53 gene. And option D is all of the above. Question number 19. Pre-malignant lesion at highest risk of malignant transformation is option A, homogeneous leukoplakia, option B, erythroplakia, option C, oral lichen planus, option D, oral submucous fibrosis. The last question, question 20. Which of the following is not associated with oral submucous fibrosis? Malignant transformation potential of 10%. Option B, trismus. Option C, betel nut chewing. Option D, blanching and shrunken uvula. So this is like a compulsory question. Would you practice oral screening and tobacco counseling in your routine after this workshop? Option A is yes. Option B is no. Option C is I want to start ICanCaRe Tobacco Wellness and Oral Screening Center. Option D is I want to get trained in tobacco intervention. A very, very pertinent question. So compulsory question 2 is TrisCare, the innovative mouth opening device for trismus care made of POM material, which is unbreakable, gives sturdy mouth opening, can measure the grading and improvement of mouth opening. You would like to order the same for your patient. The options are please contact me, I want to order. Option B is I want it available in my hospital pharmacy. Option C, I will ask my patient to purchase it online. And option D, I prefer the age-old methodology. Answers will be available on the community page.
So thank you, Dr. Mitali. And I think that was a wonderful set of questions for the quiz. And I'm sure we have got almost 80 people who have already submitted the quiz answers. And we are still waiting for more. We give 10 minutes before we close the accepting the answers. So Dushyant, you want to say something?
Thank you, Dr. Pawan. And thank you, Dr. Mitali, for this comprehensive quiz questions. They were really all-encompassing of entire day's knowledge. And there was a lot of participation on the day one also. Dr. Pawan, will you like to tell something about that?
Yeah, we had almost 131 people giving their answers on the day one, and of which almost 82 have been shortlisted. And today, by now, almost 68 have already given the answers, and we are still there is some more time for people to put in their answers. So it has been a great journey for the 2 days. I'm sure everyone has enjoyed it. There has been a learning for each and everyone. And I think every faculty, from the chairman to the organizers to our advisory committee, they have done really excellent to advise us to make this whole program something which means where everyone would benefit. So thank you so much, and I hand it over back to Shruti, and then I think Dr. Shumesh is still there. Then of course we have Dr. Hina. Dr. Mitali, would you share your experience with this?
So yeah, Dr. Pawan, thank you for the opportunity, and it's always wonderful collaborating. This is my second year that have had this opportunity to contribute, and I really congratulate you on the initiative. And Dr. Dushyant, you have been really instrumental in taking this forward as well in the capacity of the FHNO. So my best wishes to this this ICanCaRe. Really, you all are doing a great job.
Thanks. Thanks. I think we have got Dr. Nathani here. Over to Dr. Nathani, Dr. Keshav. You please unmute, sir. Dr. Keshav, you need to unmute. Yeah. Unmute, please. Unmute. Shruti, I think he's not able to unmute. You will have to release that. We had disabled the unmute option. So you will have to.
Yeah, now, sir, you can unmute yourself. I've also enabled for other participants.
Yeah. Everyone now can unmute. Yeah, please. Dr. Nathani, over to you. Yeah, now we can.
Thank you to all, Dr. Pawan, entire team of ICanCaRe, all chairpersons, moderators, speakers, and all panelists for excellent, wonderful academic session. Very informative presentation and panel discussion today on day 2 of scientific session. Great learning, sir. So since today, basically the day 2 was, it was dedicated to dental professional are an important and integral part of, the oncology care. Different, this is the dentistry cancer and area of responsibility, what I can say, to effectively prevent as well as treat oral complication. Dental professional play an important role prior to, during, and following active cancer, the treatment. All treatment modalities of head and neck cancer, they produce complications. As the entire panel discussion, including surgeries, mutilations, and psychological changes, radiation therapy, the mucositis, dysphagia, hyposalivation, posterior radionecrosis, and non-adjuvant, adjuvant, and the concurrent chemotherapy, mucositis, taste changes, immune suppression. Additionally, newer target therapies may also result in the oral mucosal complications. For improved outcome, it is imperative that for thorough oral assessment, implementation of basic oral care protocols, management of pre-existing dental conditions, and prevention and management of emerging oral complication be completed before head and neck treatment. And this is best accomplished by integrated teams with oncology trained, experienced dental providers who provide timely dental treatment and prevent protocols that do not disrupt, the entire cancer therapy. The oncologist and dentist must collaborate to optimize care as well as to increase knowledge of preventive and therapeutic options for oral health maintenance, oral cancer detection, and suitable referral condition with pathways. The oncology team should include dental professionals specialized in head and neck cancer survivor management, which will contribute to better oral complication prevention, detection, and treatment, and improved quality of life. It was a wonderful session, sir, and thank you so much to everyone. And I'll request Dr. Reena R. Kumar, ma'am, to please.
Thank you, Dr. Nathani. Thank you so much for those, very appropriately summing up things. So on behalf of ICanCaRe, Foundation of Head and Neck Oncology, Sterling Cancer Hospital, and of course, our institution, Gujarat University, at the ICanCaRe Second International Oral Cancer E-Conclave, I thank each and every one of you to be here, especially our esteemed faculty, chairpersons, very importantly, our quiz master, the leads in various forms that we have had today, and of course, our delegates, our participants who have been very interactive, and there were fantastic questions and fantastic interactive things coming over on the chat all the time. So today, what we have actually, reached, as rightly put by you, Dr. Nathani, is that oncologists collaborating with dental specialists, it is definitely there, but it has to be synergistic, because that's what we talked about. And it is to be interdisciplinary versus multidisciplinary. So now the question comes is, very rightly put by our, our lead in the panel discussion. So Dr. Ash put it out saying that now the team which has to be working for oral cancer, we have understood that, and we have reached that consensus that it has to be a leadership team. It has to be a leadership team. It has to be an interdisciplinary team, which believes that there is a patient in the center of everything. It is a patient care-centered professionals, group of them from different disciplines, as we all discussed today, all different disciplines, with each person having a shared voice and power. So nobody is more powerful than the other. Everybody has an equal voice with clear and concise communication. The word communication has come up numerous times today. And of course, seamless data sharing, because if you do not have data sharing, how are we going to treat this patient who's gone through numerous set of disciplines of patients, professionals, and what is really happening? I think the seamless data sharing part of it, where technology comes in, and when we harness cutting edge medicine techniques, because today we have heard so much of that, and also work such that it is best, as you rightly said, for the quality of life of the patients and for the best treatment outcomes for our cancer patients, oral cancer, head and neck cancer patients. Of course, the day started with our talking about our, the iatrogenic problem of ORN. And with ORN, there's one thing that we heard, again, communication, good communication. So that went on and on from everybody. Great practice guidelines, which was again put out by our panel lead. So Dr. Abhishek again put it out and said there is a guideline and we have to follow. And what I liked really best, I think we need to hold it closest to our heart. We really need to closest to our heart. What Dr. Ashish said, if the patient refuses to go to the dental surgeon, lose the patient. It is better to lose the patient. So that is the kind of importance he has given to the dental surgeon. Thank you, Dr. Ashish, for putting this. Actually, you have put in one line the crux of the entire ICanCaRe Sterling Hospitals, head and FNHO, as well as what Gujarat University, what we are trying to put across through this, that all of us need to be there. Take cutting edge technology, take technology which sometimes is not We need to use things like hyperbaric treatment, which can be given adjunctively but you cannot do it by yourself. You have to use some surgical debridement, give some proper antibiotic therapy. And what has come out of this is the need for innovation, because we need to find cheaper made in India products, which are probably available, because it was very, very well said by Dr. Sandeep that, cost is a problem, availability is a problem. And when by the time the patient has come for hyperbaric, for osteoradioid necrosis, he is penniless. How do you give that benefit of the treatment to that patient unless we actually create something? So this is where trismus management has come in. And I think there were beautiful surgical things showed by Dr. Neeti. I mean, it's amazing. But yes, I think nowhere along can we leave the mechanical aspect of it, because again, everybody talked about prevented. Dr. Neeti also, Dr. Kataria, they all went on prevention. So if you have to prevent for 13 crore people with OMSF who might be potential cancer patients, with such kind of implication, which can have psychological to all the way to to depression, alienation, feeling lonely because you're really not going to be able to speak and be communicative in the community, and of course your deglutition and mastication and everything. So TrisCare, the product of innovation. So innovation is the need of the hour, and it is innovation which takes us, to another dimension. And of course, we understand that what is currently available in the national and in the international markets are expensive, difficult to use. And this is where identification of high-risk patients using the gadgets which are made in India, like TrisCare, I invite each and every one of you to try the product, accept the product, work on research on this product, because it's only research which is going to validate this product of ours. And this product has come with a validation from Gujarat University. So there is a team behind it which has worked not only on the design, on the material, on the kind of the compressive and the tensile strength which it has, the torsion it can extract. So it is an opportune moment, I believe, that we need to look at prevention and put prevention in place where it is, because trismus is all about, we all learned it today again, is dose related effect of radiation. There are different methodologies which we heard being spoken about, by which you can kind of cut the the dosage and how you can work on it. So many cutting edge technologies, way of learning using these new things, but giving a mouth opening, mechanical, simple, easy to use device to our patients as a preventive measure itself. And starting from there would be one of the simple learnings, and I would say a takeaway, because innovation is the need of the hour. Interdisciplinary treatment or multidisciplinary with good communication, such that we work as an interdisciplinary coordinated team with each one having an equal voice. Thank you so much. I leave you all with that thought. And most importantly, before I close, I'd like to thank all our quiz participants for taking part in it so enthusiastically. And of course, Dr. Bitali and the team leaders just conducting everything so fantastically. Thank you so very much for making it so special for all of us at ICanCaRe. Grateful for all of you being here and making it happen. Thank you so much.
Thank you, ma'am. And it has been a great day. I think 3 hours just disappeared without seamlessly, and it was just full of knowledge. So I open this forum. If anyone wants to say anything, we will just keep it open for 10 minutes, and otherwise we will request everyone to please switch on their camera so that we can take a group photo. Dr. Abhishek, everyone who is there right now. I can see Nandita also there, Nandita Divekar from UK, Satyendra Jha. If you can just switch on your camera. Yeah, Abhishek, if you can. Yeah, so nice to see you, Abhishek.
I think we need to put everybody in focus and get me off it.
Yeah.
Because everybody else is more important than me just now. Let's put everybody in focus.
Please wait. I know you want to go.
I'm not going anywhere. I'm right here. But let's put Dr. Abhishek. Let's put Mitali. Let's put such people, because I think they've been just fantastic. They've just driven the entire program. Thank you so much.
Let's have everyone whoever is possible. Kirti, I can see. Premjit ji, namaskar. So nice to have you. Sir, we are looking forward for the tobacco con very soon in July. You being part of it.
Dr. Pawan, this was such a wonderful day.
Premjit has been there even the last session. I couldn't acknowledge your presence, Premjit, but I did see you. Thank you for being here with us.
I hope
for being there always. Sanjita, hi.
I'll request everyone to please put on the videos. I'm going to take a screenshot, a snapshot of a picture on the count of 3. So is everyone ready? So all smiles, please, on the count of 3. 3, 2, 1, and here we go. Okay, let me just check if the picture is good. Yeah, it's all good. It's all good. Thank you so much.
Thank you
so much.
Thank you so much. Thank you for the opportunity. Thank you so much, sir.
Thanks, Abhishek. Your slides were terrific. And you have put everything so nicely.
Pleasure, sir. Pleasure.
So we are just flooded with compliments for the panel discussion, and most of the participants have been asking for the slides and the re-repeat of the video for the panel discussion because we're so infused with knowledge and information. So I just request, sir, if it's possible to share the slides.
Absolutely.
I would like to hand it over to the participants.
But Dr. Vaidya, Dr. Abhishek, what I will be doing is, because a lot of questions probably from the prosthetic part of it was not really answered today, I will make sure that it is in the next session that we have a great prosthetic rehabilitation lecture, which is going to fill in those gaps, because there were lots of gaps which will be filled in. And I think the dental perspective will get completed. What you started out today was a great start. And I think we should be able to fill those and plug the knowledge, layers coming in the next week.
I hope I could justify the brief which was given to me, and I could, incorporate as many as. Thank you.
You were perfect. You were perfect.
So I think it can only be known from the comments. I mean, from the comments we have on the chat box and the social media. I mean, it's just flooded. It's just flooded.
Aji, Dr. Keshav. Dr. Keshav, bolo, aap video chala.
Dr. Pawan, today the panel discussion was awesome, isn't it?
All lectures were awesome. Just look at Dr.
Dr. Abhishek, great, sir, great.
It started wonderfully with Dr. Srinivas giving
Dr. Srinivas till, the panel discussion, and then followed by Dr. Sumit Chandra, concluded by you and Reena, Dr. Reena.
Yeah.
Awesome, sir.
Okay, so I think with everyone's permission, I'll close the meeting for the day because it's already 3 hours.
Yeah, please.
Have a very lovely week ahead, and we'll see you all next week. Thank you so much.
Thank you, everyone, at 4 p.m. on day 3 on next Sunday on 17th of April with the topics on rehabilitation. So see you soon. Have a great weekend ahead. Thank you, everyone. Have a great time ahead. Thank you.